Hello guys, welcome back to the PW Med YouTube channel. So today in this live lecture, guys, we are going to revise the whole of radiology in just 4 hours, right? So I will be showing you images and you have to try to look at the images and try to identify the findings, right? After identifying the findings, just put your answers in the chat section. Also, what you can do, you can download the PDF which is available on our Telegram group, and you can make notes along with the lecture, right? So let us begin, guys. Let us begin. So I have divided the session into four parts. In the first part, we will be discussing about CNS radiology. In the second part, we will be discussing about the chest radiology. In the third part, we will be discussing GIT and hepatobiliary radiology, and in the fourth part, we will be discussing MSK radiology, right? So beginning with the first image. So basic is we should know how to identify whether an image it is a CT image or it is an MRI image. So the basic rule is that always have a look at the bones. If the bones are appearing bright, it means it is a CT image. It means it is a CT image. And if the bones are appearing black, it means that it is an MRI image, right? So we should know when are we going to use a CT scan, when are we going to use an MRI image, right? So CT scan is basically used for all the cases of trauma. In the trauma, we need a very early diagnosis. CT scan takes just few minutes to acquire a CT scan, whereas an MRI will take around 30 minutes. That is why CT is the modality of choice in all cases of trauma. So you have to tell me, CT scan is the investigation of choice in all cases of trauma, except what is the exception here? In which case CT scan will not be helpful for us in a case of trauma. Anyone in the comment section? Hi Dr. Tarakanta, hi Dr. Tejas. So tell me, in which case CT scan will not be the investigation of choice in patient with trauma? It will be your diffuse axonal injury. CT scan will not be the investigation of choice, right? Whereas your MRI, it is the investigation of choice in all patients with tumors, with demyelinating disorders, with infections. MRI will be the investigation of choice, right? So let us have a look at the various sequences of the MRI. How to identify which one is a T1 weighted sequence, which is a T2 weighted sequence, which is a flare image, which is a hi Dr. Bedakulin, hi Dr. Dipanshu, hi Dr. Akhil, how are you doing? So we have divided this session into 4 hours. In the first part, we are discussing the CNS radiology, right? So let me tell you how to identify a sequence. So guys, what is the mnemonic for T2 weighted image? The mnemonic is water appears white on T2. World War II is the mnemonic. World War II. So you will see, if you look at this image, you will see that CSF is running in the sulcal spaces. And these sulcal spaces, these are appearing bright. It means that this is a T2 weighted image. Right? Is everyone clear with that? Just give me a thumbs up. Dr. Bedakulin, Dr. Real Guy, Dr. Dipanshu. Water appears white on T2. When water appears black, when your CSF appears black, what are the two sequences which will have black CSF? One is your T1 weighted image, and the other will be your flare image, right? So if you look at this image, you will see that the CSF is appearing black. In this image also the CSF is appearing black. So here what will happen? You will get confused whether an image is a T1 weighted image or it is a flare image. So can you tell me how will you differentiate between a flare image or a T1 weighted image? I will tell you. Guys, look at the white matter. Till now you guys must not be looking at the white matter. So now what you will do? you will look at this white matter. If you look at this white matter, you will see that on a T1 weighted image, white matter is white. White matter is brighter than your gray matter. But on a FLAIR image, what does FLAIR stands for? Fluid attenuated inversion recovery sequence. Basically, your fluid signal is suppressed from the T2 weighted image. This is a T2 weighted image. We will suppress the fluid and then we will get a FLAIR image. And if you look at the T2 weighted image, you will see that the white matter is black. White matter is black on T2 weighted image, and that is why on a FLAIR image also, you will see that the white matter will be black. Right? Now talking about the fourth sequence. The fourth sequence is a post contrast image. Remember, post contrast image is a T1 weighted image. Now you will ask me, sir, how will we identify whether a sequence is non-contrast or it is a post-contrast? Look at the meninges. If you will see the meninges, you will see that there is some enhancement in the meninges. You can also see the vessels running in the subarachnoid space in a post-contrast image. And if a section of ventricles is available, you will see that there will be enhancement in the ventricles. Right, in the choroid plexus of the ventricles. Right. So are you clear with the T1 weighted image, T2 weighted image, FLAIR image and post contrast image? Is everyone clear with it? Just give me a thumbs up if you are clear. So just remember that any cystic lesion will appear hyperintense. Any cystic lesion will appear hyperintense on T2 weighted image, and on the corresponding FLAIR image it will show suppression. Right? And on the post contrast images, any tumor that is supplied by a lot of vessels, because contrast will run into that tumor, that tumor will enhance on post contrast image, right? So all the tumors, only the solid component of the tumor, remember that the cystic component of the tumor is not supplied by any blood, right? So cystic component of the tumor will not enhance, but the solid component of the tumor, it will enhance. So how do you identify post contrast image? देखो, post contrast image के लिए look at the vessels. You will see veins. Look at the ventricles also. You will see enhancement in the choroid plexus of the ventricles. The choroid plexus is a very vascular structure. That is why on the post contrast T1 weighted image it is going to enhance. Right, MBBS synapse, Sanyansh, Akhil, Deep, is that right? Okay. So post contrast image we will use in all the tumors, and all the tumors they are going to enhance on the post contrast images. Whereas FLAIR sequence will be used to look for any edema, right? So whenever there is a tumor, it is going to cause mass effect on the adjacent structures, and because of this there will be edema in the surrounding brain. Even your granulomas and TB, okay, they will be having a surrounding edema. You must have read about the neurocysticercosis. So the question is asked, in which stage edema is not seen. So how do you look at that edema? So that edema will be seen in the FLAIR image, right? So here in this image, what I'm trying to show you, that there are few ring enhancing lesions in the left frontal lobe, and there is mild edema surrounding these lesions. These are your tuberculomas, right? So coming to the next sequences which we should know, very important sequence, that is your diffusion weighted imaging. So diffusion weighted imaging, it is used in everyone, guys, with me. It is used in acute infarct. Acute infarct. It will be used in tumors. All the tumors are going to show diffusion restriction. Diffusion restriction. One cyst that is going to show diffusion restriction, that is your epidermoid cyst. Epidermoid cyst is going to show diffusion restriction. And we have brain abscess. Brain abscess, that is also going to show diffusion restriction. So just remember these 4 important pathologies which are going to show diffusion restriction on DWI images. So anything which appears bright on diffusion weighted imaging, that is showing diffusion restriction. But in order to prove that that organ is showing diffusion restriction, you have to see the corresponding ADC maps also. If something is showing diffusion restriction, it will appear bright on diffusion weighted images and it will appear dark on the ADC maps. It will appear dark on the ADC maps. Is that right? Any structure which appears bright on diffusion weighted imaging, it has to appear dark in order to call restricted diffusion within that structure, right? So these are the 4 pathologies which are going to show diffusion restriction. And the fourth sequence that I am showing you here is your susceptibility weighted imaging. Susceptibility weighted imaging. Remember, this is used to look for any hemorrhage or any calcification, right? So if there is any tumor that is showing hemorrhage, for example your craniopharyngioma, it can show hemorrhage. Or if there is any tumor like oligodendroglioma which is showing calcification. So both these hemorrhage and calcification will show blooming foci. They will appear as dark spots on SWI image. So this was asked in the NEET PG exam also. Your microbleeds which are seen in patients of hypertension, they are very well visualized on this sequence. That is your susceptibility weighted imaging, right? So is everyone clear? With all the sequences? And how to identify a diffusion weighted image? Remember, it will be an image of poor quality. Okay, this diffusion weighted image will be of poor quality. You will not be able to see the skull vault, you will not be able to see the subcutaneous tissue, and the quality of the image, it will also be very poor. And your CSF, it will appear dark. This is the way to identify a diffusion weighted imaging. You can say, sir, CSF is appearing dark in this image. It can be a T1 weighted image also, it can be a FLAIR image also. No, because the quality of the image is poor, it is a diffusion weighted image. Right? So look at the normal anatomical structures. So this can be asked. Identify the structure marked in the given image. Let us see who is able to answer it. I am giving you 10 seconds to answer this question. Everyone, guys. So the structure marked in the given image is anterior commissure. So anterior commissure is basically connecting your 2 frontal lobes, 2 cerebral hemispheres, that is your frontal lobes, basifrontal lobes, and it is appearing hypointense because it is a white matter tract. What is this? Can you help me label this structure? In this image. Very good, Dr. Saqib. Label the structure that I have encircled in red. Come on, guys, I'm waiting for your answer. The structure labeled in red is your Sylvian fissure. And what is running in the Sylvian fissure? You have the M2 segment of the middle cerebral artery. So let me just quickly identify all the structures for you. So here we have Here we have a white matter tract connecting the two frontal lobes. This is the genu of corpus callosum. Genu of corpus callosum. So for corpus callosum, you should know two important tumors which are going to involve the corpus callosum. These are your glioblastoma multiforme, and the second is lymphoma. This part is your basal ganglia, deep gray matter nuclei. This is the caudate nucleus. This is the lentiform nucleus. This is your thalamus. And posteriorly you can also see that this is the hypointense tract connecting the two cerebral hemispheres. This is the splenium of corpus callosum. So can you name one condition in which corpus callosum will be absent? So in that condition you will see that this structure connecting the two cerebral hemispheres, that will be absent. This hypointense structure connecting the two cerebral hemispheres, it will be absent. What is that condition? And what is the name of sign? When you will see that corpus callosum will be absent in a patient, that is your corpus callosum agenesis, in which corpus callosum will be absent, and you will see a racing car sign. Moving on to the other structures, let us see. This is your superior sagittal sinus. Remember all the vascular structures, whether it is your anterior cerebral artery, whether it is your superior sagittal sinus, inferior sagittal sinus, all these will appear as flow voids. Flow voids means they will appear dark. So in this image you can see that the superior sagittal sinus, it is appearing dark on T2 weighted image. So can you name one condition in which this superior sagittal sinus will appear bright? So that is your superior sagittal sinus thrombosis. In which you will get a delta sign. So guys, हमें पढ़ना भी ऐसे ही चाहिए, ठीक है? जब भी हम कोई भी सब्जेक्ट पढ़ रहे हैं, उसमें कुछ भी टॉपिक आ रहा है, we have to think about all other things that we have read in the other subject also, ठीक है? अगर हमने सुपीरियर सजाइटल साइनस पढ़ा यहाँ पे, तो सुपीरियर सजाइटल साइनस से रिलेटेड कुछ भी आपके माइंड में आ रहा है, जस्ट ट्राई टू रिकॉल दैट थिंग. इन दैट वे यू विल बी एबल टू रिमेंबर द थिंग्स फॉर अ लॉन्गर पीरियड ऑफ टाइम. Talking about stroke, so stroke can be classified as hyperacute, acute, subacute and chronic. It can be hemorrhagic also, and it can be non-hemorrhagic also. Right? So why do we get a NCCT done in a patient with stroke? To look for any hemorrhage. So if a patient is having an hemorrhagic stroke, thrombolytics will be contraindicated. That is why an NCCT needs to be done. Now this hyperacute stroke is the stroke which is less than 1 day old. Acute is between 1 to 7 days. Subacute is between 7 days to 21 days. And chronic is more than 21 days. So let us have a look at the imaging features of hyperacute stroke on NCCT images. But first of all, we should know what is the earliest imaging modality of choice for hyperacute stroke. Earliest imaging modality in which imaging features will appear as early as 30 minutes. What is the imaging modality of choice? in hyperacute stroke, in which imaging features will appear as early as 30 minutes. So this is the imaging modality of choice. What is this sequence? What is this sequence? Everyone guys in the comment section. Everyone in the comment section. Tell me which is this image? Which is this image? Which sequence is being shown here? So this is a diffusion mirrored imaging. Diffusion mirrored imaging. At 30 minutes to 6 hours, you will see no signs of stroke on NCCT images. That is why diffusion mirrored imaging is the imaging modality of choice. And here in this patient, which presented with left side hemiparesis, you can see areas of infarct involving the right temporal lobe, and these corresponding areas on the ADC maps, these are appearing dark, right? And guys, when there is a diffusion flare mismatch, what do you understand by diffusion flare mismatch? When we can see some hyperintensities on the diffusion mirrored imaging, but no hyperintensities are seen on the flare image. In that case, you are going to give a thrombolysis to the patient, right? Thrombolytic drugs to the patient. So remember, if in the family, if someone in your family, okay, or your distant relative has history of hemiparesis of one side, you get an MRI done, you see areas of hyperintensity on the diffusion mirrored imaging, but on the flare images everything is fine, then you are going to give thrombolysis to that patient. So these are hyperacute signs seen in the hyperacute ischemic stroke on NCCT head. So tell me, what are the signs? In the image A? What is being shown to you in the image A? Anyone in the image A? What is the sign that is being shown here? So there is some hyperdensity in the region of MCA. This is your dense MCA sign. In the second image, we can see that there is some, this is because of the thrombus, in the middle cerebral artery, and thrombus within the middle cerebral artery will appear hyperdense. That is why you are seeing this dense MCA sign. In the second image, you can see that there is a dot shaped hyperdensity in the sylvian fissure. This is a thrombus in the M2 segment of middle cerebral artery. And this is your sylvian dot sign. In the third image, we can see that there is some hyperdensity seen adjacent anterior to the pons. And what is running anterior to the pons? We have your basilar artery, and this basilar artery is appearing hyperdense. So this is your dense basilar artery sign. And in the fourth image, we can see that this is your insular cortex, right? On the right side, we can see that your gray white matter differentiation is maintained on the right side, but it is absent on the left side. So this is known as loss of insular ribbon sign. And in the fifth image, just tell me what is the sign that you can see in the fifth image. What is the sign that you can see in the fifth image? In the fifth image, we can see that the basal ganglia is not very well visualized. basal ganglia is not very well visualized. If you can see on right side, basal ganglia is seen, but on the left side you can see that basal ganglia is not seen. Basal ganglia is not seen. This is obscuration of lent. This is your obscuration of the lentiform nucleus. Lentiform nucleus. Here again, okay, so this question can be asked. You can be given an history that a patient has history of right-sided hemiparesis. Right-sided hemiparesis. An investigation is done for this patient. What is the investigation that is being shown to you in this image? What is the investigation that is being shown to you in this image? Anyone? What is the investigation that is being shown? So guys, this is a newer imaging modality, that is your CT perfusion image. CT perfusion image. It can tell you the amount of blood that is flowing into the brain. So red color will denote that there is increased blood flow. Blue color will denote that there is decreased blood flow. And if you compare it with the corresponding NCCT images, here in this image you can see that on the left side your basal ganglia is appearing hyperdense. Basal ganglia is appearing hyperdense. But on the right side, you can see that the basal ganglia is not seen. Basal ganglia is not seen. Okay, so on the right side you can see the basal ganglia is not very well visualized, right? So this is your obscuration of the lentiform nucleus seen in a patient with hyperacute infarct. And also you can see that this area of the brain is showing decreased blood flow, because it is appearing blue. So you just need to know that what is the imaging modality. This is your CT perfusion image. Now guys, what are the imaging features of acute ischemic stroke? So just remember the 4 important features: that there will be a wedge-shaped hypodensity. Will be seen. Then you will see that there will be loss of gray-white matter differentiation. Will be seen. And you know, because there is some injury in the brain, it will get filled with fluid. There will be edema, and that edema is going to compress on the adjacent structures. पे compress करेगा. इसको बोलते हैं mass effect. Here in this image you can see that this infarct, it is causing mild effacement of the left ventricle. So this was all about your acute infarct. Talking about the subacute infarct, there is one phenomenon that you should know, that is your CT fogging phenomenon. In the CT fogging phenomenon, you will see that the hypodensity which was appearing in the NCCT images on acute infarct, it will disappear on the subacute infarct. And this is what we understand by CT fogging phenomenon. And this happens because edema decreases, and there is some hemorrhage within the infarct. Because of it, its density increases. So the infarct which was appearing hypodense in the acute stage, it starts appearing like the normal brain parenchyma, and this is your subacute infarct. Talking about the chronic stroke. Now this brain tissue, it will be replaced by the fluid. And it will start appearing like the CSF on the NCCT images. So your chronic infarct, you will see areas of CSF attenuation. And what is CSF attenuation? CSF attenuation is that it is appearing black. Chronic infarct will appear black, like your CSF. like your CSF, and you will see that there will be X vasodilatation of the lateral ventricle also, X vasodilatation of the lateral ventricle also. So what are lacunar infarcts? So any infarct which is less than 2 centimeter in size and it is presenting as a pure motor stroke. So question will be asked, what are the important sites of lacunar infarct? Important sites are basal ganglia, internal capsule, corona radiata, and your brainstem. So let us try to answer this question. Young patient presented to the emergency with right-sided hemiparesis and vision loss. Diffusion mirrored images show infarct involving the left MC territory, and also we can see diffusion restriction in the left occipital lobe. There is an infarct involving the left MC territory, and there is another infarct involving the left occipital lobe. So how is this occurring? Is this due to the occlusion of the internal carotid artery? If internal carotid artery would have got occluded, then you would not see any infarct in the region of occipital lobe. Occlusion of both anterior and posterior circulation. This is a very rare thing, when both the anterior and the posterior circulation will be occluded, right? And what is PCA? Fetal PCA. So guys, normally you will see that your posterior cerebral artery and basilar artery is arising from the vertebral artery is arising from the subclavian artery. But in some cases you will see that this posterior cerebral artery, it is arising from the internal carotid artery. Just listen to me very carefully. Posterior cerebral artery is arising from the internal carotid artery. So in that case, if there is some thrombus in the internal carotid artery and there is presence of fetal PCA also, in that case you will see that there will be infarct involving the MC also, and there will be an infarct involving the occipital lobe also. So basically there is a vessel which is forming the posterior cerebral artery, which is arising from the internal carotid artery, and this is known as fetal PCA. So patient presented to the emergency with altered mental status, vertical gaze palsy. An MRI of the patient was done and showed infarct in the region as involved. So let me tell you what is the region of infarct. The region of infarct is your thalamus, both the thalamus and the right occipital lobe. So now there is an infarct that is involving both the thalamus as well as the right occipital lobe. So can you think of a condition when there will be an infarct on both sides? So just remember, when there is a thrombus, it is going to occlude just one artery, like in the previous case. Okay, there was one thrombus in the ICA that was causing infarction in the MCA as well as posterior circulation. There is very less likely that there can be multiple thrombus that are causing infarction. So here what was happening, there was an infarct in the artery of Percheron. So this artery of Percheron, it supplies both the thalami as well as your occipital lobe. That is why when there is an infarct involving the artery of Percheron, you will see that there will be dark areas in the ADC map in both the thalami and the right occipital lobe. Identify the investigation marked shown in the image. Identify the investigation. Is this a CCT image? No, this is not a CCT image, this is not an MRI image, this is not a PET scan. This is your digital subtraction angiography image. Okay, it is used to look for any aneurysm, to look for any thrombus within any artery, intracranial artery. You will do a digital subtraction angiography. So This is another DSA image. The patient is very young and he has history of stroke. In a young patient there is history of stroke, and you do a DSA for this patient, you get this appearance. What is this appearance? Everyone guys, what is this appearance? What is this appearance? So this is your puff of smoke appearance. Puff of smoke appearance. It is seen in Moya disease. So you will see in this Moya disease what will happen. There will be narrowing of the internal carotid artery. Narrowing of the internal carotid artery. In order to compensate for that narrowing, multiple collaterals will be forming in the brain. Multiple collaterals will be forming, and these collaterals will give a puff of smoke appearance. These collateral channels which are supplying your brain, this will give a puff of smoke appearance. Now coming to the trauma part. We have completed the infarct. Hope you are clear with the imaging features of acute infarct, subacute infarct, chronic infarct. Now let us have a look how to identify a bleed. So if you are able to see any hyperdense areas, any bright areas on the NCCT images, these will be areas of bleed. And here in this image you can see that this bleed is appearing biconvex in shape. This bleed is appearing concavo-convex, and here you can see that this bleed is seen within the brain parenchyma. So what is this first case in which the bleed is appearing biconvex? This is a extradural hemorrhage. And remember, this extradural hemorrhage, these patients will have a lucid interval. Lucid interval means that the patient will be normal at first, okay, will be unconscious, then he will gain some consciousness, and after that he will again become unconscious. So this part of the time in which the patient is regaining consciousness, this is the lucid interval in which will be seen in a patient with extradural hemorrhage, and it is due to the rupture of the middle meningeal artery. In the second case, you will see that this is seen in subdural hemorrhage. It will be seen in old patients with history of trivial trauma. If they fall while taking a shower, okay, they can develop this subdural hemorrhage. And this subdural hemorrhage, it is due to the rupture of the cortical bridging veins. In old patients, what happens? There is atrophy of the brain, and because of this cortical veins which are traversing through the brain into the superior sagittal sinuses, they get stretched, and when these veins are stretched, they are very prone to rupture, and that is why with trivial trauma also they can have a subdural hemorrhage. And how do you identify an intraparenchymal bleed? So intraparenchymal bleed can be identified by looking for edema. An intraparenchymal bleed, there will be areas of hypodensity surrounding the bleed. Areas of hypodensity can be seen surrounding the bleed, and here in this patient we can see intraparenchymal hemorrhages in the right frontal lobe. Now what is being shown in this NCCT image of the head? In this image we can see that there are hyperdensities along the basal cisterns. So this hyperdensity is basically your blood in the basal cisterns, and this is seen in a patient with subarachnoid hemorrhage. In subarachnoid hemorrhage, you will see hyperdensities in the sulcal spaces in the basal cisterns, and it is due to the rupture of the berry aneurysm. And what is the most common site of berry aneurysm? It is the junction of ACOM with the anterior cerebral artery. Junction of ACOM with the anterior cerebral artery. So this patient had history of trauma. You examine this patient, there is pulsatile proptosis in this patient. You are getting an CCT done for this patient. What do you see on this CCT head of this patient? Can you tell me what are the imaging findings in this CCT head of this patient? Anyone, Medico Forever, Manas Agarwal, Vikas Verma, Vivek Kumar. What are your imaging findings in this CCT head of this patient? What are your imaging findings for this CECT head of this patient? In this image we can see that your superior ophthalmic vein, it is prominent. And we can see that the cavernous sinuses also, they are prominent. And why are they getting prominent? Because no, this is not compression of optic nerve tralogue. So this is your superior ophthalmic vein, this is your cavernous sinus. So they are prominent because there is some fistulous communication. Because of the trauma, there is some fistulous communication with the ICA with the cavernous sinus. So when the arterial blood starts flowing, remember ICA is flowing through the cavernous sinus. Just remember the diagram of the cavernous sinus. So you can see that in the cavernous sinus you have the intracavernous part of ICA, and whenever there is trauma, okay, there can be a trauma to this internal carotid artery, it will start communicating with the ICA, it will start communicating with the cavernous sinus, and in that case you will see that this cavernous sinus will get filled with blood. And what is flowing into the cavernous sinus? It is your superior ophthalmic vein, and you will see that in this patient there is prominent superior ophthalmic vein, prominent cavernous sinuses, and this is the case of carotico-cavernous fistula. Carotico-cavernous fistula. Now this patient had history of non-improving altered sensorium. NCCT head was done for this patient. On NCCT head, you see that the NCCT head is completely normal. You do an MRI for this patient. And what are these? These are your SWI images. On SWI images, you can see areas of blooming, foci of blooming can be seen in the gray white matter junction, So these are basically your microbleeds. So this happens in a case with diffuse axonal injury. I told you that NCCT head is the imaging modality of choice in all patients of trauma except diffuse axonal injury. So diffuse axonal injury will present as microbleeds in the area of gray white matter differentiation and gray white matter junction and your corpus callosum. Most common site of hypertensive bleed is your putamen. So many patients, okay, they will have history of hypertension, they will come to the emergency with altered sensorium, okay, or hemiparesis, and you will see area of hyperdensity in the region of basal ganglia, and this is also causing mass effect in the form of effacement of the left lateral ventricle, left lateral ventricle. Coming to another sign of trauma. Here we can see that there is black collection anterior to the brain, So there are two structures which appear black on NCCT images. So this is your fat, and the second is air, which appear black. So this is not your fat, this is your collection of air just anterior to the brain, and this is known as Mount Fuji sign, seen in patients with tension pneumocephalus. So guys, can you tell me what is the source of air? What is the source of air in these patients? What is the source of air in the extra-axial spaces? Let me see who can answer this. What is the source of air in this extra-axial space? Source of air. It is your fracture of the frontal sinuses. So from frontal sinus, the air can go into the extra-axial space, and this will give you a pneumocephalus appearing as a Mount Fuji sign. A newborn presents with congestive heart failure, resistant to treatment. On examination, has bulging anterior fontanelle with a Bruin auscultation. Transfontanel ultrasound shows hypoechoic midline mass with dilated lateral ventricles. So what is the most likely diagnosis? This was asked during my NEET PG exam. What is the most likely diagnosis? Encephalocele? No, it will not present with congestive heart failure. Medulloblastoma, it will not appear hypoechoic. Arachnoid cyst will appear hypoechoic, but it will not present with congestive heart failure. The answer is vein of Galen malformation. So what is vein of Galen malformation? It is due to the persistent vein of Galen, in which there are arteriovenous communication, and because of this the vein of Galen, or the remnant of the vein of Galen, that is your prosencephalic vein, median prosencephalic vein, it becomes dilated. So the blood is going from the arteries directly into the veins, and from the veins it is going directly into the heart. So the patient is presenting with high output cardiac failure, because a lot of blood is going into the heart directly from the arteries into the veins, and the heart is not able to manage it. So what will happen? It will go into congestive heart failure. And because of this, hypoechoic, because of this dilated vein, it is going to compress onto the anterior aqueduct of Sylvius. And when it compresses onto the anterior aqueduct of Sylvius, it will result in hydrocephalus. That is your dilated ventricles. So patient presenting with midline cystic swelling, hydrocephalus and congestive heart failure, you will think of vein of Galen malformation. Hyperintense corticospinal tracts on T2 varied MRI images. Wilson disease, no, you will see panda sign. Lacunar infarcts will not, no lacunar infarcts. Then it is seen in patients with amyotrophic lateral sclerosis, in which you will see hyperintense corticospinal tracts. Just look at the precentral sulcus. There is some hyperintensity in the precentral gyri. Then there is some hyperintensity in the internal capsule, and there is some hyperintensity in the cerebral peduncles. So this is your tract of the corticospinal tract, in which you are seeing hyperintensities. MR imaging of multiple sclerosis will show lesions in white matter, gray matter, thalamus, basal ganglia. Anyone? MR imaging in multiple sclerosis will show lesions in anyone? So let me wait for your answer. Let me wait for your answer. So MR multiple sclerosis will show lesions in the white matter, right? Because it is a demyelinating disorder. Very good, Manas. Very good, Shifana. So it is a demyelinating disorder, and in demyelinating disorder, your myelinated fibers will be involved, and out of the gray matter and white matter, which fibers are your myelinated fibers? These are your fibers of the white matter, fibers of the white matter. So in multiple sclerosis, you will see plaques. You will see plaques which will appear hyperintense on T2 weighted and FLAIR images, and this hyperintense plaques on T2 and FLAIR images, this will appear as Dawson's finger, Dawson's fingers arranged perpendicular to the callososeptal interface, Another one more sign that you can see in multiple sclerosis is your dot dash sign, in which you will see dot and dash shaped hyperdensities along the roof of the lateral ventricle. Dot and dash shaped hyperdensities will be seen along the roof of the lateral ventricle. Extensive involvement of deep white matter with bilateral hyperdense thalamus on non-contrast CT scan of MRI brain. On CT scan of brain is virtually diagnostic of, very good, Shifana. So this is virtually diagnostic of Krabs disease, in which you will see bilateral hyperdense thalamus, So remember your biochemistry also. What is deficient in Krabs disease? Anyone, guys? Your biochemistry must be better than me. It is due to the deficiency of galactosyl ceramidase enzyme. So let us have a look at the various leukodystrophies. So guys, normally what happens, you're on T2 weighted images, your white matter appears black. Whenever there is some injury to this white matter, or whenever there is some demyelination occurring in the white matter, it appears white, right? So this was happening in multiple sclerosis also, in which you were seeing demyelinating plaques which were appearing hyperintense. So these leukodystrophies, these are also demyelinating disorders. So we will see how to identify these leukodystrophies. So if any leukodystrophy, this is a FLAIR image, and we can see that there is hyperintensity involving the parieto-occipital region. This is your X-linked adrenoleukodystrophy. If it is involving the parieto-occipital lobe, it will be your X-linked adrenoleukodystrophy. If it is involving both the frontal lobes, which leukodystrophy will be this? Involving both the frontal lobes. Anyone, guys? In the comment section, what is the leukodystrophy involving both the frontal lobes? It will be your Alexander disease. If it is involving both the cerebral hemispheres with sparing of the subcortical U fibers and giving a tigroid pattern, it will be your metachromatic leukodystrophy. And if the subcortical U fibers are also involved, it will be your Canavan's disease, in which you will see NAA peak on MRS. NAA peak on MRS will be seen. So clear with all the leukodystrophies? So this is a patient presenting with hydrocephalus. Then you have multiple ring enhancing lesions, and you have enhancing basal exudates. And you can also have infarcts also in these patients. So these basal exudates, infarcts and hydrocephalus, these are characteristic features of your tuberculous meningitis. In which stage of neurocysticercosis is edema not seen? Vascular stage, colloid vascular stage, granular stage, or calcified stage? Anyone in the comment section, in which stage of neurocysticercosis edema is not seen? It is the first stage and the last stage, that is your vascular stage and the calcified stage. You will not see any edema. And if you look at the images, how does neurocysticercosis look like? You will see multiple cystic lesions on T2 virid images. Multiple cystic lesions will be seen, and within those cystic lesions there will be an eccentric scolex. Will be seen, which will appear hypointense, and this is known as dot within a cyst sign. Multiple cystic lesions are seen, and if you look at the cystic lesions, few of the lesions they are also showing edema around it, which is appearing hyperintense on the FLAIR image. Why is this a FLAIR image? Because the white matter is appearing dark, and if you look at the ventricles are also appearing dark, and that is why this is a FLAIR image, which is used to look for any edema. So the last stage of neurocysticercosis gives a starry sky appearance. Multiple calcified lesions in the brain gives a starry sky appearance, and this is also seen in ultrasound. In a patient with hepatitis, you will get a starry sky appearance. Then in PSGN on immunofluorescent images, and in patients with Burkitt's lymphoma, you will get a starry sky appearance. A patient presents with fever, headache and altered sensorium. MRI of the patient was done, which is shown below. So what are your imaging findings for this patient? So in this patient we can see that there is hyperintensity seen along the medial temporal lobe. Hyperintensities are seen along the medial part of the temporal lobe, and your medial temporal lobe, it is involved in HSV encephalitis, which is going to involve your limbic system, that is your hippocampus, parahippocampal gyrus. Then it is going to involve your insular cortex. You will see hyperintensities, and the patient has history of fever and altered sensorium. So let us have a look at another case. So this case, it is showing these are your post contrast images. It is showing a peripheral enhancement on post contrast images. The lesion is appearing T2 hyperintense. And on diffusion weighted images, it is showing restriction. So guys, this is a case of brain abscess, peripherally enhancing lesion showing diffusion restriction and appearing hyperintense on T2 virid images. So I told you diffusion, 4 important pathologies. One is acute infarct, second brain abscess, third epidermoid cyst, which I am going to show you, and fourth is brain tumors, which are going to show diffusion restriction. So another one-liner periventricular calcification, it is seen in CMV, cytomegalovirus. So on in toxoplasmosis, you are going to see an eccentric target sign, eccentric dot sign, sorry. You are going to see an eccentric dot sign. Just remember this sign of toxoplasmosis, eccentric dot sign. Face of giant panda sign on MRI is seen. Face of giant panda sign on MRI is seen in. Very simple question. It is seen in patients with Wilson's disease, which is the metabolism of which is due to the deposition of copper, which is due to the excessive deposition of copper. And within the eyes, what you are going to see? You are going to see KF rings. And within the midbrain, you are going to see this face of giant panda sign, in which there is hyperintensity involving the tegmentum of midbrain, and it is sparing your red nucleus. Hyperintensity involving the tegmentum of midbrain with sparing of the red nucleus. Sparing of the red nucleus, giving the face of giant panda sign. And what do you see in Wernicke's encephalopathy? Wernicke's encephalopathy, you will see hyperintensities along in the adjacent to the third ventricle. This is your third ventricle, and you are seeing hyperintensities in the adjacent to the third ventricle, and you are also seeing hyperintensities in the dorsomedial thalami. So these patients will be alcoholic. Alcoholic history will be mentioned in the question, and you will see hyperintensities in the adjacent to the third ventricle, periaqueductal gray matter, and your dorsomedial thalami. And in Japanese encephalitis, we will see that there will be hyperintensities involving the basal ganglia, bilateral thalami, T2 hyperintense lesions in the both the basal ganglia. Bilateral hyperdense thalamus was seen in, come on guys, we have already discussed this. Bilateral hyperdense thalamus was seen in Krabs disease, right? So bilateral T2 hyperintense lesions in the thalamus. On MRI, it is seen in Japanese encephalitis, and bilateral hyperdense thalamus on NCCT head images will be seen in Krabs disease. Eye of tiger sign on MRI brain is characteristic of Haller-Botten Sparks disease, in which your globus pallidus will appear hypotense. Globus pallidus, it is appearing hypotense, and there will be areas of gliosis within it. Areas of gliosis will be seen within it, which will appear T2 hyperintense. Areas of gliosis will appear T2 hyperintense, and this will give a sign that is known as eye of tiger appearance. One we studied tigroid pattern in the bilateral cerebral hemispheres, that was seen in metachromatic leukodystrophy. Then another tigroid appearance in the cerebellum. Tigroid pattern in the cerebellum is seen in Lermite-Duclos syndrome, in which there is widening of the cerebellar folia, which will give this tigroid pattern. And in this image, what are you able to see? What are you able to see in this image? Anyone, guys? What are we able to see in this image? So this is your molar tooth appearance of the midbrain. So this molar tooth appearance of the midbrain, it is seen in Joubert syndrome. In which there will be Vermean hypoplasia. Vermean aplasia will be seen, and your midbrain, it will appear like your molar tooth. So a patient presented with abnormal eye movements and decreased cognition, you do an MRI for this patient and you see that your midbrain, it is appearing like hummingbird, it is appearing like hummingbird, and on the axial images it is appearing like your Mickey Mouse. It is appearing like your Mickey Mouse. So this hummingbird sign and Mickey Mouse sign, this is seen in patients with progressive supranuclear palsy. Progressive supranuclear palsy. Patient presented with cognitive deficit, involuntary hand and finger movements and muscle incoordination. What is your probable diagnosis? CAG repeats are also seen in this patient. CAG repeats are seen in this patient. You look at the ventricles, the ventricles appear like boxcar shaped ventricles are seen, and the caudate nucleus, there is atrophy of the caudate nucleus is seen. So all these features are of Huntington's disease. Coming to the brain tumors, which is the most common brain tumor? Most common brain tumor is your metastasis. Most common primary brain tumor is your meningioma. Most common intraparenchymal brain tumor. Most common intraparenchymal brain tumor is glioma, and most common intracranial tumor to calcify is your craniopharyngioma. So just remember these most important things. And if we look at the imaging modalities, the investigation of choice is contrast enhanced MRI brain. In all the brain tumors, investigation of choice will be contrast enhanced MRI brain. Role of CT is done to look for any hemorrhage within the brain tumor, to look for any calcification. Lesions like your oligodendroglioma, your craniopharyngioma, they are going to show hemorrhage and calcification, right? On an MR spectroscopy, you will see that they will have a choline peak, and Na levels will decrease, and also remember that alanine peak is seen in patients with meningioma. So let us quickly look at the various imaging findings in the brain tumors. First of all, we should know how to differentiate between an extraaxial and intraaxial lesion. So extraaxial means that that lesion is lying outside the brain tissue. So any lesion that is lying outside the brain tissue, it will be surrounded by CSF. And it will give a CSF vascular cleft sign. Any lesion that will be lying outside the brain, it will be surrounded by a CSF, like this is a case of meningioma. If you look at the meningioma, it is surrounded by CSF on all sides, and within that CSF your vessels are running. That is why it is going to give a sign that is known as CSF vascular cleft sign. Patient presented with recurrent headaches. An extraaxial dural based enhancing lesion was seen. The most likely diagnosis is, so here in this image, CECT head image, we can see that there is a avidly enhancing lesion with a broad base towards the dura, and it is showing avid enhancement. So this is your meningioma. So what are the other signs that you can see on NCCT head? You will see that there will be hyperostosis of the underlying bone in a patient with meningioma. You will see that if this is your meningioma, there will be enhancement of the dural tail. This is known as dural tail sign. And this meningioma, it will appear hyperdense on NCCT head. And let me tell you that most of the brain tumors, these appear T2 hyperintense. Most of the brain tumors, they appear T2 hyperintense, whereas your meningioma, it will appear T2 isointense. It will appear T2 isointense. And there will be alanine peak on MRS. There will be alanine peak on MRS. Which of the following is the most common cause of cystic solid supracellular mass on cranial MR of a 10-year-old child? Most common cause of mixed cystic solid supracellular mass on cranial MR of a 10-year-old child. So just remember that the most common supracellular solid cystic mass is that of craniopharyngioma. So there is one 90-90 rule for craniopharyngioma, which says that 90% of the lesions will be cystic, 90% of the lesions will show calcification, and 90% of the lesions will be seen in the children. Right? This is your 90-90 rule for craniopharyngioma. So if you look at this case, this is your sella, and there is one lesion that is seen in the supracellular location. And this lesion, this is a post-contrast image, post-contrast T1 vivid image. And if you look, that some part of the lesion is appearing black and some part of the lesion it is appearing bright. This is because it is a mixed cystic solid lesion. And as I told you that on post-contrast images, only the solid component of the lesion will show enhancement, whereas the cystic component of the lesion, it will not show any enhancement. 7-year-old child presented with a posterior fossa mass having a cyst, having a nodule within a cyst appearance. So this is your posterior fossa. This is your post-contrast T1 vivid image. Here we can see this lesion. So there is some cystic component within the lesion which is not showing any enhancement, and there is some solid component within the lesion which is showing enhancement. So this nodule within a cyst appearance, this is shown by pilocytic astrocytoma in children. So also remember that cyst with a nodule appearance, it is also seen in gangliocytoma, then it can be seen in pilocytic xanthoastrocytoma. It can also be seen in hemangioblastoma. This hemangioblastoma, it will present in adults. So let us have a look at the various signs that you are going to see in the brain tumors. So the first image, it is showing you bracket calcification, bracket shaped calcification. This is an NCCT image. So tell me, this bracket shaped calcification, this is seen in which brain tumor? Bracket shaped calcification. This is a fat attenuating lesion, that is why it is appearing black on NCCT head images. This is seen in corpus callosum lipoma. A lesion is seen in the CP angle, and this lesion is seen to extend into the internal auditory canal, giving a ice cream cone appearance. This lesion is seen in anyone. Ice cream cone appearance is lesion is seen in vestibular schwannoma. And vestibular schwannoma, just remember that it is associated with neurofibromatosis 2, in which you are going to see multiple inherited schwannomas, meningiomas, and ependymomas. So the mnemonic is miss me. multiple inherited schwannomas, meningiomas and ependymomas. So this lesion, it is involving the corpus callosum and it is extending onto the contralateral hemisphere, giving a butterfly appearance. This is seen in glioblastoma, right? And the last lesion which is having a figure of 8 appearance, it is showing homogeneous enhancement. It is seen in case with pituitary macroadenoma. So here again we can see that there is some cystic lesion anterior to the temporal lobe. Cystic lesion is seen anterior to the temporal lobe, that is T2 hyperintense, and on the corresponding FLAIR images it is showing suppression. On the corresponding FLAIR images. So this is the case of arachnoid cyst. So we should know how to differentiate an arachnoid cyst from a epidermoid cyst. So just remember that if a lesion is appearing dark, on the diffusion weighted images, it is an arachnoid cyst. And if the lesion is showing diffusion restriction, like this lesion in the left cerebellopontine angle, this will be a case of epidermoid cyst. So these are few cystic lesions within the brain. So how to differentiate? Arachnoid cyst is lying in the common Sylvian fissure, most common location. Epidermoid cyst CP angle. No diffusion restriction is seen on arachnoid cyst. Diffusion restriction is seen on arachnoid cyst. It will appear bright on diffusion weighted images. It will appear dark on diffusion weighted images. So medulloblastoma versus ependymoma. So just remember that medulloblastoma, it is going to arise from the roof of the fourth ventricle, whereas your ependymoma, it is going to arise from the floor of the fourth ventricle. Ependymoma is a plastic tumor. It means that if it is extending into the fourth ventricle, from the fourth ventricle, this can extend into through the foramen of Luschka into the CP angle. So here we can see that there is some lesion in the fourth ventricle, and it is seen to extend through the foramen of Luschka. Because it is a plastic lesion, it can extend anywhere, whereas medulloblastoma will not extend through the foramen of Luschka, and it will appear hyperdense. Medulloblastoma will appear hyperdense on NCCT images. Your ependymoma, it will be a solid cystic lesion. Cystic component can be present within the lesion, whereas medulloblastoma is a more homogeneous lesion. You will not see hemorrhage or cyst within the medulloblastoma. So let us have a look at few neurocutaneous syndromes. So can you identify the first syndrome? This is the first neurocutaneous syndrome. Tell me, what are you able to see? What are your imaging findings for this case? So in the first case, we can see that there is tram track calcification, and there is port wine staining of the face, and this is seen in a patient with Sturge-Weber syndrome. So what are the other features of Sturge-Weber? They can be remembered with the mnemonic STURGE, where S stands for seizures, T stands for tram-track calcification, U stands for unilateral hemiparesis, R for mental retardation, and G for glaucoma. These are the other features that you can find in patients with Sturge-Weber syndrome. Now coming to the second image, anything that you can diagnose using these two images. In the second image, we can see that there are multiple papules on the face. Multiple papules can be seen on the face. And in the first image, we can see that there are multiple nodules in the subependymal location. So these are your subependymal nodules, and there is one avidly enhancing lesion in the region of foramen of Monro. This is your subependymal giant cell astrocytoma. So this saga subependymal nodules with multiple papules. This is your adenoma sebaceum. Multiple papules on the face. This is a case of tuberous sclerosis, right? So just remember, in tuberous sclerosis you can also find within the kidneys you can find angiomyolipoma, other tumors which can be found in the tuberous sclerosis. Then within the heart you can find rhabdomyosarcoma, right? Rhabdomyosarcoma. Now guys, moving on to the next image. What are you able to see in these images? So this is a contrast enhanced CT image of the head, in which we can see a solid cystic lesion in the posterior fossa. Solid cystic lesion can be seen in the posterior fossa. So this is your hemangioblastoma. In the second image, we can see that there are multiple cysts can be seen within the pancreas. Multiple cysts can be seen in the pancreas. And we can also see few lesions can be seen in the kidneys also. Solid cystic lesions can be seen in the kidneys also. Very good, Dr. Meghavi Patel. Okay. And in the third image we can see that there is some lesion that is located just superior and anterior to the kidneys. This is a pheochromocytoma. So all these features, pheochromocytoma, then your hemangioblastoma and pancreatic cyst, these can be present in a patient with von Hippel-Lindau syndrome, right? So talking about few congenital anomalies. So in this first image we can see that this is a normal patient, and in the second patient we can see that there is a large posterior fossa cyst. There is hypoplasia of the vermis. This is seen in patients with Dandy-Walker malformation. And in the second image we can see that there is herniation of the tonsils. Through the foramen magnum. So this is seen in a patient with Arnold-Chiari malformation. So for Arnold-Chiari malformation, just remember that during antenatal scan you can also see the lemon sign. Lemon sign can be seen in Arnold-Chiari malformation, right? So guys, this was all about neuroradiology. So now let us begin with the few images from the section of chest radiology. So guys, let us have a look at the normal chest x-ray. What do we have to look at the normal chest x-ray? Anyone guys? What are the normal structures that we have to look? So you must have seen the normal reporting of chest x-ray. You will look at the lung fields, you will look at the lung fields, you will look at the heart. So normally this ratio of the heart to the thorax, it is less than 0.55 in adults and 0.60 in children, right? So if this is more than 0.55, this cardiothoracic ratio, very good Yuvraj, we will look at the CP angles, also. So when the cardiothoracic ratio is more than 0.55, it means that there is cardiomegaly in these patients. Cardiomegaly is present in these patients. And if you look at the costophrenic angles, okay, if these costophrenic angles, these are appearing sharp in this patient, but whenever there is pleural effusion, there will be blunting of the costophrenic angle. And you should know how much pleural effusion can cause blunting of the costophrenic angle. It is approximately 200 to 300 ml. 200 to 300 ml can cause ml of pleural effusion can cause blunting of the costophrenic angle. Also we will look at the hyla. So normally this hyla, it is formed by the pulmonary artery and superior pulmonary vein and pulmonary artery. So it is forming an acute angle. Whenever there is blunting of this angle, it means that there is some lymphadenopathy in this patient, and this lymphadenopathy can be seen in patients with tuberculosis, can be seen in patients with sarcoidosis. And also remember that always this left hilum is higher than the right hilum. Higher than the right hilum. And a question that you can get in your NEET PG exam is, what are the hidden areas of the lung? So these hidden areas include apex of the lung, then you have your mediastinum, then retrocardiac area, and you have the area of the lung below the diaphragm. Okay, area of the lung below the diaphragm. These are your hidden areas of the lung we should always look at. And last, we should also look at the bones. ठीक है, bones भी देखनी है हमें. So guys, when we are doing an X-ray, we will encounter 5 densities. So these 5 densities will include the density of air, which is appearing black. Okay. Then the density of fat will be which will also be black. Fat will also appear black. Then your water. Okay. Then your water which will appear white, bright, and brighter than water will be your bones. And more brighter than bones will be your metallic artifacts. So these are the 4 densities that you are going to encounter in a chest X-ray, in any X-ray. And also guys, you should see that if you look at the margins of the diaphragm, they are very sharp. Margins of the diaphragm, margins of the heart, they are very sharp. So if anywhere you are seeing that the margins are not very well visualized, then you are going to suspect that there is some pathology in that place, and that is the basis of Silhouette sign that we will study as we move ahead. Right, talking about the first X-ray. So this patient will come with complaints of fever. You do an X-ray, you see an homogeneous opacity. Radiopacity can be seen in the left upper and middle zone, and within the radiopacity there is some lucencies which is running. Radiolucencies can be seen within this opacity. So what happens in a case with consolidation? Your alveoli get filled with pus or fluid, alveoli will get filled with pus or fluid, but your bronchioles will be normal. Bronchioles will be normal. So what you will get? You will get an area of lucency, area of radiopacity, and within that area of radiopacity there will be some lucencies which will be running through it, right? And this is known as air bronchogram sign. This is known as air bronchogram sign. And you can see the similar sign on CT also. You can see that there is some consolidation involving the right middle lobe, and within that consolidation you can see that bronchioles are running. And air bronchogram sign will be seen in consolidation. This can also be seen in patients with ARDS, pulmonary hemorrhage, pulmonary edema. In these patients also you can get a air bronchogram sign. So let us discuss about few eponyms in tuberculosis. What is Ghon's focus? So Ghon's focus is basically your parenchymal lesion. What is Ghon's complex? It is parenchymal lesion plus lymph nodes. And what is Runke complex? It is parenchymal lesion plus lymph node plus calcification is there. Right? And we will see these complexes on the CT images as well. And what is Vigard's focus? Vigard's focus is any tubercular lesion involving your pulmonary vein, Rasmussen aneurysm, any tubercular cavity involving your pulmonary artery resulting in aneurysm of the pulmonary artery, that is your Rasmussen aneurysm. Then you should know Siemens focus. It is a tubercular, it is a supraclavicular tubercular focus. Is your Siemens focus, right? So these are few eponyms you should be aware of. So let us have a look at these lesions now. So what will happen? The patient will with TB, he will come with complaints of fever, he will come with complaints of weight loss. You will see areas of consolidation and you will see multiple nodules. Centrilobular nodules will be seen in this patient, and these centrilobular nodules, these are going to give a tree in bud appearance. Right? Tree in bud appearance will be seen in tuberculosis. And within the mediastinum, you will see multiple enlarged necrotic lymph nodes will be seen. So we have Ghon's focus here. We have Ghon's focus plus lymph nodes, which is your Ghon's complex. And when there is calcification in this lymph node, we will call it as Runke complex. And these nodules will have a tree in bud appearance. Right? So sometimes what will happen? There will be cavitary changes will be seen. So you should know cavitary changes are seen in reactivation of old tubercular focus, also known as post primary tuberculosis or secondary tuberculosis. You will see areas of cavitation. And when there are multiple nodules scattered in both lungs, okay, multiple nodules seen in random distribution scattered in both the lung parenchyma, you will say it is a case of miliary tuberculosis. There is hematogenous spread of the tubercular bacilli, because of which nodules are seen in the random location in the entire lung. This is your miliary tuberculosis. And here in this CT pulmonary angiography, you can see that there is some aneurysm that is involving the pulmonary artery. There is aneurysmal dilatation of the pulmonary artery. This is your Rasmussen's aneurysm, and this patient will come with complaints of massive hemoptysis, right? Now guys, let us have a look uh, at the imaging features of aspergilloma. So in the first image we can see that there is some crescentic shaped air around the crescentic sign can be seen. So this is known as Monod sign. So Monod sign is seen in fungal ball. Monod sign is seen in fungal ball. So you are seeing that there is some cavitary lesion, and within that cavitary lesion there is some fungal ball formation. Because of which you are getting this sign that is known as Monod sign. In the second case, you are seeing that you will see that the patient will have history of asthma. And on NCCT chest images, you will see that there are multiple dilated bronchi seen in the central part of the lung. Multiple dilated bronchi will be seen in the central part of the lung. This is your central bronchiectasis. Central bronchiectasis with history of asthma will be seen in which patients? It is your allergic bronchopulmonary aspergillosis. Right? And when these dilated bronchi they get filled with mucus, it will give a finger in glove appearance. Right? So finger in glove appearance will be seen in allergic bronchopulmonary aspergillosis. Now guys, coming to another fungal infection in which you are going to see an area of consolidation, and surrounding that area of consolidation you will see various ground glass opacities. So this is known as your halo sign. Very good. This is known as halo sign, and this halo sign it is seen in invasive aspergillosis. This halo sign it is seen in invasive aspergillosis. So basically your Aspergillus fumigatus fungus, it is invading your pulmonary arteries. It is causing hemorrhage. Because of this hemorrhage, there is an area of consolidation. There is an infarcted lung which is giving this consolidation, and surrounding that consolidation there will be ground glass opacities, right? And we should know one more sign, that is your reverse halo sign. Reverse halo sign is seen in cryptogenic organizing pneumonia. It is seen in cryptogenic organizing pneumonia. Okay. Now talking about this sign in a patient with invasive aspergillosis. So guys, there was some necrosed lung. And what happens? Okay, this infarcted part of lung tissue, it will retract. When this infarcted lung tissue retracts, it will give a crescentic shaped air around it. And this is known as air crescent sign. So just remember that Monod sign, which is very similar to this, it will be seen in a patient with fungal ball. And your air crescent sign, that will be seen in a patient with invasive aspergillosis. So now let us have a look at the few signs of collapse. Okay, so what are the direct signs? So direct signs will include that whenever there will be collapse of some part of the lung, okay, that area will appear increased in density. Okay, so here we can see that this part of the lung, that is your right upper zone, it is collapsed. Okay, so it is appearing increased in density. This is the direct sign. And what are the indirect signs of the lung collapse? Indirect signs will include that there will be shift of the trachea. Here in this image we can see that there is collapse of the left lung, and because of this collapse, the trachea, it has shifted to the left side. And other indirect signs, we can see that there will be compensatory hypertrophy of the right lung. So few named signs. Can anyone tell me what are the few named signs in the patient with collapse of the lung? So tell me, what are you able to see in this image? In the first image, what are you able to see? Anyone, guys? What are you able to see in the first image? Just look at the hidden areas of the lung. So if you look at this area very carefully, you will see that there is some homogeneous opacity in the left lower zone. Okay, so that is why, you know, retrocardiac area is one of the hidden area of the lung. Sometimes you can mistake this homogeneous opacity for the shadow of the heart, but this is not the shadow of the heart. This is the hidden area in which there is homogeneous opacity, there is collapse of the left lower lobe, and this is your flat waist sign. In the second image, we can see that there is some homogeneous opacity in the left upper zone. Homogeneous opacity can be seen in the left upper zone, and there is also some sickle shaped air collection around the arch of aorta. Sickle shaped air collection can be seen around the arch of aorta. It is due to the compensatory hypertrophy of the contralateral lung. You can see that there is a sickle shaped air around the arch of aorta. So this is seen in left upper lobe collapse, and it is known as Luft-Sichel sign. So Luft means air and Sichel means sickle shaped. Coming to the third image. In the third image, we can see that there is some opacity in the right upper zone. Okay, it is pulling the fissure towards itself and taking the shape of the S. So in the collapse of the right upper lobe, you will see a golden S sign. And in the last image, we can see that there is some homogeneous opacity in the right middle zone, and it is resulting in loss of silhouette of the right heart border. I told you when we were discussing the normal X-ray that all the heart borders should be very well visualized, but in this image we can see that the right heart border is not very well visualized, and as well as we can see some homogeneous opacity in the right middle zone. This is your silhouette sign seen in right middle lobe consolidation / collapse, right? So these are few named signs that you should know. So guys, I'm showing you two X-rays. In one X-ray, okay, in both the X-rays there is some homogeneous opacity in the left lung parenchyma. Okay, so let me label these X-rays A and B. So out of these X-rays, you have to tell me which one of the X-ray is showing collapse and which one of the X-ray is showing pleural effusion. You just have to use your common sense and you will be able to come to the answer. Let me see who is able to answer this in the comment section, guys. So you have to label the X-ray and you have to tell me which one of the following is a collapse and which one of the following is pleural effusion. Come on, guys, tell me. Out of the X-rays A and B, you have to tell me which one of the X-ray is showing pleural effusion and which X-ray is showing collapse of the lung. Anyone, any cases? I want every one of you to answer. Dr. Sachin is saying A is pleural effusion. Dr. Yashwant is saying collapse is seen in the B. Dr. Yuvraj, A pleural effusion. Can you also give one reason for calling A as pleural effusion? One reason also. So if you are answering it well, you guys are doing very well in radiology. Let us see who is able to answer this with a reason also. One reason to call pleural effusion X-ray A and one reason to call collapse in the X-ray B. Collapse in the X-ray B. One reason, guys. So let me tell you the answer now. So guys, in the X-ray A, we can see that this is your trachea. This is your trachea. And because of this effusion, this trachea, it is shifted to the right side. That is why this opaque left hemithorax, this is a case of pleural effusion, because it is pushing the trachea towards other side. Whereas in this image, you can see that the trachea is shifted towards the ipsilateral side of the opacity. Very good, Dr. Yashwant, very good. So in the image B, you can see that the trachea is shifted towards the ipsilateral side, and this is a case of collapse of the left lung. One more case, one more a very interesting X-ray. Let me see who is able to identify what are the findings in this X-ray. Let me see who is able to identify the findings in this X-ray. Just look at this X-ray carefully. Just look at all the normal things that I told you, whether it was lung fields, whether it was your CP angle, whether it was your heart, okay, hidden areas of the lung, and let us see who is able to identify the findings in this X-ray. And this is a very important findings that even radiologists can miss. When we are looking X-rays very fast. Can anyone tell me what is the finding in this X-ray? Yashwant, Yuvraj, Angelina Jain, Sachin, what is your finding? You want more time? No, there is no bronchiectasis. No bronchiectasis is seen. Tubular heart, no, the heart appears normal. The heart appears normal in this patient. Anyone else? Cervical rib, no. This is the first rib. This is not your cervical rib. Just look at the 5 things that I told you. A hint is also mentioned. A hint is also given in the X-ray. A hint is given in the form of arrows. Can you look at the arrows? No Chetan Alava, cardiac notch. Hyla is also normal. Pneumothorax is not there. In pneumothorax, you will see a visceral pleural line. You will see a radiolucent area that is devoid of lung markings. Hyla appears normal. Can you tell me the findings now? So X-rays may look very simple when you are looking at it, but they are not so. Even radiologists can miss these findings. Very good, Sachin, very good. Okay, so there is fracture involving the ribs on the left side. There is fracture of the ribs on the left side. So always look at the bones. That is why I didn't give you the history of trauma in this patient. Then it would have been very simple for you, right? So a child has respiratory distress. Chest X-ray shows multiple air-filled spaces. The differential diagnosis is all except. So this is again a common sense question. Congenital lung cyst. Congenital lung cyst will have air-filled spaces. So this is out. Congenital diaphragmatic hernia will have bowel loops. Bowel loops will have air spaces. This is again out. Now we have two options left: congenital lobar aplasia of the lung and congenital adenomatous malformation. So out of the two, what do you think will be the answer? Congenital lobar, will you see any cystic lung spaces in the? No cystic lung spaces will be seen in aplasia of the lung, right? Congenital adenomatous malformation, you will see multiple cysts within the lung, right? Multiple cysts within the lung will be seen in the congenital adenomatous malformation. So let us have a look at this X-ray, right? So let me tell you that CCAM, that is your congenital adenomatous malformation, you will see multiple cystic spaces within the lung. Okay, so that is same. Okay, now you should know how to differentiate between CCAM, that is your congenital adenomatous malformation, and your congenital diaphragmatic hernia, right? So congenital diaphragmatic hernia, it will push the diaphragm toward, it will push the trachea towards the opposite side, whereas CCAM, it will not shift the trachea. So if you are seeing multiple cystic spaces in the lung, okay, think of these two conditions, CDH and CCAM. If trachea is shifted, then go for CDH, right? So what is Bokdalek hernia? Bokdalek hernia, okay. In Bokdalek hernia, you will see that there is defect in the posterolateral aspect of the diaphragm, and there is herniation of the bowel loops through that defect. And here in this image, we can see a cystic lucency in the right upper zone, right? And this is seen in patient with congenital lobar overinflation. Congenital lobar overinflation. Now look at this X-ray. Look at this X-ray and tell me what are your findings. What are your findings in this X-ray? Apply those principles. Apply those principles that I have told you. Apply the principles that I have told you. So Bokdalek and Morgagni hernia, you will differentiate based on their location, right? If you know there is defect in the posterolateral aspect, right, you will say it is a Bokdalek hernia. Okay. Morgagni hernia is mostly seen on the right side. Very good, guys. Amazing, Yashwant. Amazing, Sachin, Yuvraj. So here we can see multiple calcified lymph nodes can be seen. Multiple calcified lymph nodes can be seen, and this is a case of sarcoidosis. And if you do a gallium scan for this patient, you will see a panda sign, in which there will be increased uptake in the lacrimal glands. Increased uptake will be seen in the parotid glands, and there will be the normal uptake. Increased uptake will be seen in the nasopharyngeal mucosa. You will see increased uptake, and together these uptakes, these are going to show a sign that is known as panda sign. All are seen in congestive heart failure except Curley B lines, prominent lower lobe vessels, pleural effusion, cardiomegaly. All are seen in congestive heart failure except. Come on, guys. So guys, in congestive heart failure, you will see cardiomegaly, you will see pleural effusions, you will see Curley B lines. Only thing that will not be seen will be your prominent lower lobe vessel. You will see prominent upper lobe vessels. Will be seen. right? So let us have a look at the various stages of the congestive heart failure. So in the first stage, you will see cephalization of blood vessels. There will be redistribution of blood flow when the pulmonary capillary wedge pressure is between 13 to 18 mm. You will see prominent upper lobe vessels, and this gives a sign that is known as stag antler sign, or inverted mustache sign. In the second stage, you will see perpendicular lines to the pleura, 1 to 2 mm in thickness, 2 to 6 centimeter in length. These are your curly B lines. So in the second stage, what is happening? There is interstitial septal thickening, which is appearing as curly B lines. And in the third stage, when the pressure in the pulmonary veins start increasing, there is increase in the hydrostatic pressure in the pulmonary veins, the fluid starts leaking out of the pulmonary veins into the alveoli. When these alveoli get filled with fluid, okay, they will appear as consolidation. So you will see multiple bilateral perihilar consolidations will be seen. And these perihilar consolidations, this will give a bat wing appearance. Right? So bat wing appearance will be seen in congestive heart failure. So in the first stage, you are getting this stag antler sign due to the prominent upper lobe vessels. In the second stage, between 18 to 25 mm of Hg of capillary wedge pressure, you will see thickening of the interlobular septa, which will appear as curly B lines. And in the third stage, you will see perihilar consolidations, and this is known as bat wing appearance. Now take a look at this X-ray and tell me what is your diagnosis for this case. Anyone? Take a look at this X-ray and tell me what is your diagnosis for this case. Anyone, guys? Sachin, Vikas, Yashwant. So you are very close, Yashwant. You are very close. This is not emphysema. So in this case, we can see that there is an area of lucency involving the right lung. Area of lucency can be seen involving the right lung, and this part of the lung, it is devoid of lung markings. And you can also appreciate a visceral pleural line. A visceral pleural line can be seen in this patient. And this is a case of pneumothorax. And if this X-ray is taken in the supine position, air will collect in the costophrenic space. And this gives a sign that is known as deep sulcus sign. So let us see what are the other signs of pneumothorax on ultrasound. So this is an ultrasound image of the normal lung. This is the M mode. And in the normal lung, we can see that we are getting this seashore appearance. Whereas in a patient with pneumothorax, in the M mode, you will see barcode appearance. In M mode, right? So seashore appearance will be seen in normal lung parenchyma. Yes, there are no signs of the mediastinal shift because it is not a tension pneumothorax, right? It is not a tension pneumothorax. Okay, the pneumothorax is not that big that it is causing the mediastinal shift, right? Now looking at the signs of the pneumomediastinum. So when your air will collect in the mediastinum, we will call it as pneumomediastinum. So what it is going to do? What is present in the mediastinum? You have your branches of the arch of aorta, right? You have the heart, okay? You have the heart, you have the pulmonary arteries which are seen in the mediastinum. So air is black, air is black, air is radiolucent. So this radiolucent air, it is going to surround the organs of the mediastinum, and accordingly you will have the various names. So in the first image we can see that this thymus, it is surrounded by an area of lucency. This is known as Spinnaker sign, or angel wing appearance, We can, in the second image, in the second X-ray, we can see that there is a radiolucency below the dome, below the heart, right? This is the continuous diaphragm sign, seen in pneumothorax. And in the third image, we can see that there are few radiolucencies which are lining the branches of the arch of aorta. Radiolucencies will line the branches of the arch of aorta, and this is known as tubular artery sign. So just remember these named signs of the pneumomediastinum. Now let us have a look at few acquired heart diseases. Radiological findings of mitral stenosis are all except double atrial shadow. Yes, this will be seen. Straightening of the left heart border. Yes, it will be seen. Splaying of the bronchi will be seen. Prominent aortic knuckle will not be seen in mitral stenosis. So guys, what happens? This is your normal heart. Now this right atrium and left atrium, they are lying adjacent to each other. And that is why this right border of the left atrium does not have a separate shadow. This right border of the left atrium, it does not have a separate shadow on the chest X-ray. But when there is mitral stenosis, there will be enlargement of the left atrium, and when this left atrium is enlarged, you can see it is not lying alongside the right atrium, and this right border of the left atrium, it casts a separate shadow on the chest X-ray, and this is known as double atrial shadow. So here in this X-ray, we can see that this is the right heart border, okay, and we can also see one more shadow can be seen, and this is the shadow of the right border of the left atrium, which is known as double density sign or double atrial shadow, right? Now this atrium, okay, so between these atrium, these are lying between the two bronchi. These atrium are lying between the two bronchi, right? Imagine this is my body, this is your atrium, and these are your two bronchi. So whenever there is enlargement of the bronchi, what will happen? They will cause splaying of the bronchi, and there will be widening of the carinal angle. So what is carinal angle? It is formed by the two bronchi, and whenever there is left atrial enlargement, it will cause widening of the carinal angle, and you will also see straightening of the left heart border. Will be seen. And on a lateral X-ray, what happens? If you imagine a lateral X-ray of the patient, so in that patient, this is the trachea, and these are the two bronchi that you will see. But when there is left atrial enlargement, this left bronchi, it will be shifted posteriorly. this left bronchi, it will be shifted posteriorly. Okay, it will be shifted posteriorly, and these two bronchi will be seen separately on the lateral X-ray, and this will give an appearance that is known as walking man sign. Walking man sign. So just remember that the walking man sign is seen in the lateral X-ray of the mitral stenosis patient, in which there will be left atrial enlargement, ठीक है. सो हमने लेफ्ट एट्रियल एनलार्जमेंट के बारे में पढ़ लिया, ठीक है, लेफ्ट एट्रियल एनलार्जमेंट के बारे में पढ़ लिया. नाउ let us see prominent aortic knuckle. Prominent aortic knuckle can be seen in a patient with aneurysm involving the arch of aorta. ठीक है, तो जब भी arch of aorta dilate होगी, we will see that the aortic knuckle, it will get prominent. Aortic dissection में भी you can see that the aortic knuckle is prominent, right? So in this X-ray we can see. Now let me tell you the signs of the right atrial enlargement. So whenever the distance of the right heart border is more than 2.5 centimeter from the vertebra, distance of the right heart border is more than 2.5 centimeter from the vertebra, that will be a case of right atrial enlargement. Right atrial enlargement, right? In right ventricular enlargement, right RV enlargement, it is seen in patients with tetralogy of Fallot. And what happens, you will see that your right ventricle, it is forming the base of the heart. Okay, it is forming the diaphragmatic surface of the heart, not the base, diaphragmatic surface. So whenever there is enlargement of the right ventricle, it will shift the apex of the heart upwards. It will shift the apex of the heart upwards, right? And when this apex of the heart is shifted upwards, this is basically the boot-shaped heart that you will see. Boot-shaped heart will be seen in patients with tetralogy of Fallot, right? And one more sign that you are going to see, that you can remember, in the left ventricular enlargement, you will see Hoffmann-Rigler sign. So I will just tell you what is this Hoffmann-Rigler sign. You can just remember that it is seen in patients with LV enlargement. There will be, you will measure the distance of the posterior border of the heart from the IVC 2 centimeter above the diaphragm. You will measure the distance of the posterior border of the heart from the IVC 2 centimeter above the diaphragm. If this distance is less than 1.8 centimeter, you will call it as a case of left ventricular enlargement. And also remember that as in case of right ventricular enlargement, the cardiac apex was shifting upwards. In left ventricular enlargement, the cardiac apex will shift downwards and laterally. Okay. So anyone is feeling hungry? Looking at the biscuit, Oreo cookie. Looking at the Oreo cookie, anyone is feeling hungry? What is being shown in this image? What is the name of the sign? The name of the sign is Oreo cookie sign. Oreo cookie sign. Oreo cookie sign is seen in pericardial effusion. What happens in pericardial effusion? There is collection of fluid in the pericardial space. When this fluid is lying between the two fat planes, one is the fat in the retrosternal area, and the fat in the epicardial space. So when you do a lateral X-ray for this patient, you will see that there will be an opacity, and surrounding that opacity there will be two lucencies. Let me just draw it for you. So there is some opacity that is due to the pericardial effusion, and surrounding that opacity there will be some radiolucency. This radiolucency is due to the fat in the retrocardiac area, and this lucency is due to the fat in the epicardial region. And this will give a sign that is known as Oreo cookie sign. Oreo cookie sign. So a patient has history of swelling in the legs, swelling in the legs. He has history of breathlessness. He has history of breathlessness. You do a CT angiogram, okay, CT pulmonary angiogram, pulmonary angiography for this patient. What do you see, guys? What do you see? What do you see in this CT pulmonary angiography image? CT pulmonary angiography image. Anyone? Anyone? What are you able to see in this CT pulmonary angiography image? Just look at this image very carefully. I am giving you time and tell me. Anyone, guys? Anyone who would like to comment on this? Patient has history of swelling in the legs, swelling in the legs. Very good, very good, right? So here in this case we can see that there is a filling defect. A filling defect can be seen in the pulmonary artery. A filling defect can be seen in the pulmonary artery. This is because of the presence of thrombus within the pulmonary artery. This is a case of pulmonary embolism. Pulmonary embolism, right? So what sign you are going to see in pulmonary embolism on CT angiography image? You will see a polo mint sign. So basically you will see an artery, a cross section of the artery. The periphery of the artery will be enhancing, and within that artery there will be a thrombus. There will be a thrombus within that artery, and this will give an appearance that is known as polo mint sign. Polo mint sign. The other signs that you can remember on the chest X-ray are your Fleshner sign. This Fleshner sign, in this Fleshner sign there is prominent descending pulmonary artery. There is prominent descending pulmonary artery in Hampton's hump. Because of this thrombus in the pulmonary artery, there will be a wedge-shaped infarct. Wedge-shaped infarct in the lung. This is known as Hampton's hump. Hampton's hump. And because of the thrombus, part of the lung, okay, part of the lung will be less perfused, and that less perfused part of the lung will appear as area of focal oligemia. Focal oligemia. And this focal oligemia is known as Westermarck sign. Westermarck sign. So just remember these important signs in the pulmonary thromboembolism. Pulmonary thromboembolism, right? Now let me show you few cystic lung diseases and the question that you can get from this cystic lung disease and the related history. So in the first case you will see that the patient will have history of family history of pneumothorax. Family history of pneumothorax. You will have history of RCC in these patients, family history of RCC in these patients, and you are seeing cysts in the lower lobe. Cysts can be seen in the lower lobe. This is a case of Birt-Hogg-Dube syndrome. Birt-Hogg-Dube syndrome. So just remember that in Birt-Hogg-Dube syndrome you will see lung cysts which are predominantly located in the lower part of the lung. In the second image, what you will be given that there will be irregular shaped cysts, bizarre shaped cysts will be seen. The patient will have history of smoking. History of smoking will be present in the patient, and this is seen in patients with Langerhans cells histiocytosis, LCH. Pulmonary LCH, you will see bizarre shaped cyst, history of smoking will be present. In the third case, you can be given that the patient has history of tuberculosis, or the woman is young of childbearing age, Multiple cysts are present throughout the lung. Multiple cysts are seen throughout the lung. Can you tell me what is the finding that you will see in patients with tuberous sclerosis in the lung? We discussed the findings in the brain, that were your subependymal nodules, subependymal giant cell astrocytoma. We saw multiple papules on the face, that was adenoma sebaceum. What is the pathology in the lungs that is seen in patients with tuberous sclerosis? Anyone, guys? What is the pathology that you are going to see in tuberous sclerosis? It is your lymphangiomyomatosis, right? Lower lobe predominant, Birt-Hogg-Dube syndrome, irregular shaped cyst, LCH. Then your multiple cysts throughout the lung, well defined. It will be seen in women of childbearing age or tuberous sclerosis. It will be your lymphangiomyomatosis, right? Now looking at the important appearances of the congenital heart diseases. The first investigation is always the chest X-ray. Chest X-ray will be the first investigation in these patients. What will be the investigation of choice? Investigation of choice will be echocardiography. And what you will do for preoperative imaging? You will do a CT angio. A CT angio will be done for these patients. So let us have a look at the various appearances of the congenital heart diseases. So in the first case, we can see that it is having a egg on side appearance. Egg on side appearance, guys. It is seen in egg on side appearance. It is seen in anyone? Simple question. Transposition of great arteries. Then you have this snowman appearance. So in snowman appearance will be seen in total anomalous pulmonary venous connection. Right? It can be of various types: supracardiac, cardiac, infracardiac, and mixed variety. Supracardiac is the most common, and in cardiac type, all the pulmonary veins, they are draining into the either the right atrium or the coronary sinus. Then your boot shaped heart or Corin Sabot appearance. It is seen in tetralogy of Fallot. So what are the four things that you are going to see? You will see that there will be overriding of aorta. Overriding of aorta means that aorta is arising from both the right ventricle and the left ventricle. There is VST, there is hypertrophy of the right ventricle, and there is pulmonic stenosis in these patients. So these are the four components of the tetralogy of Fallot. And what do you see in pentology of Fallot? What is the additional thing that you are going to see? You will see that there will be ASD also in these patients. In this image, we can see that the patient is having, there is a notch present in the aortic knuckle, giving the figure of 3 appearance. So figure of 3 appearance, it is seen in coarctation of aorta. So coarctation of aorta, you will get a figure of 3 appearance, and this will also be associated with inferior rib notching. It will also be associated with inferior rib notching. And the box shaped heart, this is seen in Epstein anomaly. Box shaped heart is seen in Epstein anomaly. Right? Clear with all the appearances of the congenital heart diseases, right? So few one liners about the most common mediastinal masses. ठीक है. So overall the most common mediastinal mass, it is your thymoma. Thymoma is the most common mediastinal mass. Most common anterior mediastinal mass is again your thymoma, and thymoma, it is associated with myasthenia gravis. Myasthenia gravis. Most common middle mediastinal mass, it is your lymphoma. Most common middle mediastinal mass is your lymphoma. Most common middle mediastinal mass in children, it is your foregut duplication cyst. Foregut duplication cyst. And the most common posterior mediastinal mass, most common posterior mediastinal mass, it will be your neurogenic tumors. Neurogenic tumors. And just remember that your neurofibroma, it gives a target appearance on MRI. Target appearance on MRI. So let me just tell you how do you divide the mediastinum into three parts. So in the anterior mediastinum, it will include all the structures anterior to the anterior border of trachea. You will draw a line that is joining the anterior border of trachea with the posterior border of the heart, right? And then you will draw another line just posterior to the anterior surface of the vertebra, 1 centimeter posterior to the surface of vertebra. You will draw another line. So the structures lying between these two lines, red and blue line, will be your middle mediastinum masses, and posterior to the blue line you will have posterior to the blue line you will have your posterior mediastinal masses. Posterior mediastinal masses. ठीक है. So let us see what are the four masses which are seen in the anterior mediastinum. They can be remembered with the mnemonic 4 T's. So 4 T stands for anyone? What are the 4 T's? Very good, Pratham Patil. You have teratoma, then terrible lymphoma, thymoma we have already discussed, and you can also have thyroid mass in the anterior mediastinum. And what will be there in the middle mediastinum? Middle mediastinum, you will have trachea, you will have esophagus. So if there is any cystic lesion that is arising from the esophagus, that is your foregut duplication cyst, it will be present in the middle mediastinum. And in the posterior mediastinum, what will be the structures? You will have the sympathetic chain, you will have the nerves which are coming out through the foramina, neural foramina, right? So any tumors of the nerves, that is your neurofibroma, your paraganglioma, tumors of the parasympathetic system, or the tumors of the sympathetic system, that is your neuroblastoma, they can be present in the posterior mediastinum. ठीक है. So here in this image I am showing you one mass in the anterior mediastinum. There is some radiopacity that is having a broad base toward the pleura. It is having very well defined margins. Remember, a lung mass will not have a very well defined margin like a mediastinal mass. ठीक है. So that is why I said that this mass is having a very well defined margin, right? So this was a case of thymoma. CT was done and thymoma was seen. In this image we can see that there is some cystic lesion in the mediastinum. Cystic lesion in the mediastinum can be seen. So this is a case of foregut duplication cyst seen in the middle mediastinum. So लंग ट्यूमर्स के बारे में 3-4 पॉइंट्स, वेरी इंपॉर्टेंट पॉइंट्स डिस्कस कर लेते हैं. इनिशियल इन्वेस्टिगेशन, चेस्ट एक्सरे, ठीक है. इन्वेस्टिगेशन ऑफ चॉइस, CECT chest, right? And MRI is done in patient with Pancoast tumor, when there is involvement of the brachial plexus. To see the brachial plexus involvement, we will do MRI in these patients, right? So guys, if you are given in the question that the lesion is located is located in the periphery. It is a young woman. No association with the smoking. No history of smoking is present. Then you are going to say that it is a case of adenocarcinoma of lung. Adenocarcinoma of lung. Patient have a history of smoking. The lesion is located centrally. And it is causing cutoff of the bronchus, and because of this there is collapse of the left upper lobe. This can be seen in patients with squamous cell carcinoma. And in the third image we can see that you will be given that the patient has history of smoking will be present. There will be paraneoplastic syndromes can be given. Paraneoplastic syndromes are present in this patient, okay, or SVC obstruction is present in this patient. So SVC obstruction, it is characteristically seen with small cell carcinoma of lung. And in the fifth image we can see that there is some well defined lesion that is having popcorn calcification. This will be seen in pulmonary hematoma. Right. So these are few important points about lung tumors. So this is one triad we should know. There is one large lesion, heterogeneously enlarging lesion that is arising from the lesser curvature of the stomach. This was your gist. Within the lung you can see a well defined benign lesion showing focus of calcification. This was your chordoma, pulmonary chondroma, right? And another lesion was seen in the abdomen, in the paravertebral location. That was your paraganglioma. So can you tell me what is this triad? Of paraganglioma, chondroma and gist? Anyone? Yuvraj, Yashwant, Pratham, anyone who can tell what is this triad of paraganglioma, chondroma and gist? This is your Carney's triad. Right? So patient has history of mastectomy. He was a patient of breast cancer. Multiple round metastases can be seen in the lung. Okay, so these are your cannonball mets. So just remember, question can come, where are you able to see these cannonball mets? These can be seen in patients with renal cell carcinoma, endometrial carcinoma, right? So in these patients you can have cannonball metastasis within the lung. So guys, we are done with chest radiology, we are done with neuroradiology. Now we will have a look at few images in the section of gastrointestinal radiology, right? So let us begin. Okay. A 6-week-old child presented to the emergency with non-bilious vomiting. An olive-shaped mass was palpated in the right upper abdomen. Okay, what is your diagnosis for this case? 6-week-old child presented to the emergency with non-bilious vomiting. You palpated the patient. There was olive-shaped mass. There was also paradoxical aciduria seen in this patient. You do a You can also do an ultrasound or you can do a barium swallow. Barium swallow is not done. Ultrasound is the first modality that is done, but a barium meal image is shown to you here. In the barium meal image, we can see that there is narrowing of the pylorus. There is narrowing of the pylorus, and this narrowing of the pylorus, it is seen in congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. So what are the features that you are going to see in ultrasound? If the thickness of the pylorus is more than 4 mm, thickness of the pylorus is more than 4 mm, it is extending for a length of more than 16 mm, then you can label this case as case of congenital hypertrophic pyloric stenosis. A patient presented to the OPD with dysphagia and foul smelling breath. Barium swallow was done and image is shown below. What is your probable diagnosis? So this is a barium swallow image. We can see that there is a diverticulum arising from the posterior aspect of the esophagus. The patient has history of halitosis, dysphagia and regurgitation of food. This is seen in patients with Zenker's diverticulum. Zenker's diverticulum. Okay. So let us have a look at few images of the barium swallow. So in the first image, we can see that there is a linear defect can be seen in the esophagus. This is seen in patients with esophageal web. They are associated with iron deficiency anemia, dysphagia. Okay, can be associated with Plummer-Vinson syndrome. Okay, Plummer-Vinson syndrome. This patient had history of intake of acid or alkali. And in the barium swallow images, we can see that there is smooth narrowing seen in the middle and distal part of the esophagus. There is smooth narrowing, and this is seen in a patient with esophageal stricture. This we have already discussed. Third case, diverticulum arising from the posterior aspect of the esophagus, and this diverticulum is arising between the cricopharyngeus and thyropharyngeus muscle. And this is your Zenker's diverticulum. And when this diverticulum is arising from the lateral part of the esophagus, this is known as Killian-Jamison diverticulum. And remember that this diverticulum will be present below the cricopharyngeus muscle. Okay, very good. Dolman procedure for Zenker's diverticulum. So here we can see that the patient has history of chest pain. There is corkscrew appearance of the esophagus. Is seen, and this corkscrew appearance of the esophagus, it is seen in patients with diffuse esophageal spasm. You will see that there is corkscrew appearance of the esophagus. Worm-like filling defects in the esophagus. It is seen in esophageal varices. You will see worm-like filling defects. And in the third image, you can see that there are transverse bands can be seen within the esophagus. This is your feline esophagus. This is seen in patients with gastroesophageal reflux disease and eosinophilic esophagitis. Right. So two barium swallow images are given. In the first case, the patient has dysphagia more to liquids than to solids. And in the second image there is dysphagia more to solids than to liquid. So can you make your diagnosis using the clinical history and using the appearance of the esophagus? Very good, Yashwant. So this is the bird's beak appearance seen in patients with achalasia cardia. And in the second image we can see that the patient is having irregular narrowing of the esophagus can be seen, giving a rat tail appearance seen in patients with esophageal cancer. So patient presented with epigastric pain and postprandial fullness. You are able to see a radiolucency in the retrocardiac area. So this is a spotter that we used to do during our post graduation. ठीक है, तो इसमें क्या है, रेडियोल्यूसेंसी है रेट्रोकार्डिक एरिया में. So this radiolucency is due to the herniation of the stomach into the mediastinum, and this is a case of hiatus hernia. Can you guys appreciate this radiolucency in the retrocardiac area? Radiolucency in the retrocardiac area. This is due to the herniation of the stomach into the mediastinum. Now this was a neonate presented with breathing difficulties and feeding difficulties. The pediatrician was trying to insert this NG tube, and after that an X-ray was done for this patient. You see that there is coiling of the NG tube. Is seen, and this coiling of the NG tube, this is seen in patients with tracheoesophageal fistula, in which you are going to find esophageal atresia. Will be seen. Right, because of which there is coiling of the NG tube. And remember that the type 3 tracheoesophageal fistula, this is the most common, in which you are going to see proximal atresia and distal tracheoesophageal fistula will be seen. So this is a CT image of your friend who was an alcoholic, who was partying during his birthday. He drank a lot of alcohol, and in 4 o'clock in the morning he started vomiting very badly. You took him to the emergency, NCCT was done. What are you able to see? You are able to see that there is foci of air can be seen around the esophagus within the mediastinum. So basically there is pneumomediastinum in this patient. You do a barium swallow study for this patient. You see that there is leakage of barium into the lung. Can be seen, into the mediastinum can be seen. Basically there is leakage of barium from the esophagus, and this is a case of Boer-Haave syndrome. Right, and in Boer-Haave syndrome you are going to see this macular striate. Will be seen in Boer-Haave syndrome, in which you are going to see chest pain, vomiting, plus you will see subcutaneous emphysema. Right, so this is the macular striate seen in Boer-Haave syndrome. This we have already studied. The patient has history of non-bilious vomiting. There is thickening of the pylorus more than 4 mm in length. Okay, there is paradoxical aciduria. It is extending for a length of 16 mm. So these are the few signs that you can see in barium. So when this thickened pylorus it is projecting into the stomach, it gives a sign that is known as shoulder sign. When this pylorus is indenting into the duodenum, it gives a sign that is known as your mushroom sign. And narrowing of the pylorus gives a sign which is known as your string sign of Cantor, string sign of Cantor. And caterpillar sign is nothing but your hyperperistalsis of the stomach, hyperperistalsis of the stomach. ठीक है. So barium swallow, barium meal study can also be done for ulcers. So in ulcers, just remember the two important signs. In benign ulcer, you will see a Hampton's hump, and in malignant ulcer, you are going to see a meniscus sign. Meniscus sign. This is Karman meniscus sign. M for Karman meniscus and M for malignant ulcer. Malignant ulcer. ठीक है. So patient came to the emergency. He has history of abdominal guarding tenderness. Okay, you are getting this erect chest X-ray done. Can you tell me what are your findings in this erect chest X-ray? What are your findings in this erect chest X-ray? Anyone? What are your findings? Yuvraj, Yashwant. Very good, amazing answer, yeah. So here you can see that there is gas, there is free air. Free air can be seen under the right dome of diaphragm. So free air under the right dome of diaphragm, okay, it will be seen in a patient with pneumoperitoneum. So what are the other signs? Other signs that you can see in the pneumoperitoneum, you can see that this air is present throughout the abdomen, okay, and your abdomen will look like football. This is your football sign, okay. Collection of air around the central tendon of diaphragm, it gives a sign that is known as cupola sign. Collection of air under the central tendon. When your falciform ligament is visible, this is falciform ligament sign. Normally what happens when you are taking an abdominal X-ray, okay, only one wall of the bubble loop is visible. Only one wall of the bubble loop is visible. When both the walls, outer as well as inner wall of the bubble loops are visible, this is known as Rigler's sign. This is known as Rigler's sign, right? Rigler's sign. So can you tell me Rigler's triad is seen in? Rigler's triad is seen in. And when the liver edge is visible, this is known as liver edge sign. So these are all the named signs of pneumoperitoneum which you guys should be aware of. Now here in this image we can see that the loops are dilated, and there are multiple air fluid levels which can be seen. So when you are seeing dilated small bubble loops, dilated loops in the central part of the abdomen, and these loops are also having valvulae conjuventis, okay, valvulae conjuventis. Folds can be seen, folds of mucosa can be seen, okay. You will suspect a case of small bowel obstruction. And what is the criteria? When the loops are dilated more than 3 cm in diameter for small bowel. For large bowel it is 6 cm, and for cecum it is more than 9 cm. And on CT image, on CECT image, you will see that, you know, normally the contents of the small bowel loops is liquid, okay, is liquid, because feces has not yet formed. They will be forming in the large intestine, but due to the obstruction, you know, this small bowel contents are staying there for a very longer period of time, and feces start forming, and they will appear like air mixed with the contents of the loop. This is known as small bowel feces sign. This is known as So here in this image we can see how to differentiate between small bowel obstruction and large bowel obstruction. small bowel obstruction and large bowel obstruction. Here in this image we can see that air dilated loops are present within the central part of the abdominal cavity. We can see folds of mucosa, that is your valvulae conjunctivis, can be seen. So this is most likely your SBO, small bowel obstruction. But here in this case we can see that loops are present in the periphery of the abdominal cavity, periphery, and your valvulae conjunctivis are absent. That is why it is a case of large bowel obstruction, right? So in this X-ray we can see that there is some radiodensity in the lower part of the abdomen, that is your pelvis. Dilated loops can be seen, and there is some linear, very difficult to appreciate at your level. So radiolucency can be seen, branching radiolucency can be seen in the liver, branching radiolucency can be seen in the liver. So this is your small bowel obstruction due to gallstones, and there is pneumobilia in this patient, and this is what you understand what is present in Rigler's triad. Pneumobilia, you have gallstone ileus in the which can stuck in the terminal ileal loops, and you have dilated small bowel loops. ठीक है. So three images, single bubble, double bubble and triple bubble appearance. So single bubble sign is seen in congenital hypertrophic pyloric stenosis. Double bubble sign is seen in mnemonic is LAT bands, annular pancreas and duodenal atresia. And your triple bubble sign, it is present in ileal atresia, right? So these are your single bubble, double bubble and triple bubble signs. Okay, let us see the imaging appearance of volvulus. So in volvulus you will get a coffee bean appearance will be seen. So we should know how to differentiate between cecal volvulus and sigmoid volvulus, right? If the volvulus is reaching up to the left upper part of the abdominal cavity, it is due to the cecal volvulus. It is reaching up to the left upper part of the abdominal cavity, it is cecal volvulus. And in cecal volvulus, just remember, hostrations will be present. Hostrations will be present in cecal volvulus. They will be absent in a patient with sigmoid volvulus, and sigmoid volvulus will reach up to the right upper part of the abdominal cavity. Okay. So this patient has history of red currant jelly stools, history of vomiting is present. You do an ultrasound for this patient and you can see that there is some target appearance on ultrasound is seen, and this is a case of intussusception, in which there is telescoping of one bowel loop. Yes, triple bubble is seen in jejunal atresia. ठीक है, ट्रिपल बबल दिखेगा आपको जेजुनल अट्रेजिया में. एंड दिस इज योर बेरियम अनीमा इमेज, in which you can see the claw sign. So claw sign is seen in barium anemia in patients with intussusception, claw hand sign. Accordion sign is seen in pseudomembranous. There is thickening of the transverse colon giving the appearance of accordion, okay, and it is seen in patient with pseudomembranous colitis, ठीक है. अब कुछ इमेजिंग अपीयरेंसेस डिस्कस करते हैं. लेट अस डिस्कस फ्यू इमेजिंग अपीयरेंसेस इन दी इन्फ्लामेटरी बावल डिजीज. तो ये तो बड़ी कैरेक्टरिस्टिक अपीयरेंस है, ये तो आप सबको पता होगा. ये अपीयरेंस इसको क्या बोलते हैं? इसको हम बोलते हैं लेड पाइप कोलॉन, ठीक है. देयर इज लॉस ऑफ ऑस्ट्रेशन इन द कोलॉन, एंड दिस इज योर lead pipe appearance. Lead pipe appearance of the colon is seen in ulcerative colitis. So the first feature that you are going to see in ulcerative colitis, it will be your mucosal granularity. Mucosal granularity will be seen in the ulcerative colitis. ठीक है. Then you are going to see increased mesenteric vascularity, giving the comb shaped appearance, is seen in patients with Crohn's disease. So in Crohn's disease you are going to get this comb sign, and you can also see narrowing of the terminal ileum in these patients, and this is again your string sign of Cantor. ठीक है. Thumb printing in the small bowel loops, thumbprint appearance in the small bowel loops. This is seen in ischemic colitis. ठीक है. So can you tell me thumbprint appearance in the upper airway? Okay, where will you get this thumbprint sign? This will be seen in patients with acute epiglottitis. Also you are going to get this thumbprint sign. ठीक है. Ileocecal tuberculosis. Again you should be aware about all the named signs of the ileocecal tuberculosis. There is widening of the ileocecal angle. Gives a deformity that is known as goose neck deformity. Thickening of the ileocecal valve with gapping of the valves will give an inverted umbrella shaped appearance. This is known as Fleischner sign or inverted umbrella appearance. And string sign of Cantor will again be seen in these patients. And one more sign is Sterling sign. What is Sterling sign? Sterling sign is rapid emptying of the barium. Will be seen in these patients. Okay. So this patient came to the emergency with right lower quadrant pain. You do an ultrasound. Okay, you see one structure. Okay, one blind ending loop that was aperistaltic, that was incompressible, and this was your appendix. You measure the outer wall to wall diameter. The outer wall to wall diameter was more than 6 mm. This was a case of acute appendicitis. ठीक है. तो बच्चों हमारा काफ़ी कुछ रिवाइज हो गया. वी हैव रिवाइज दी important images from the section of neuroradiology. We have revised important images from the chest radiology and gastrointestinal radiology, right? So आगे बढ़े. Should we move ahead? So do you want to listen to something motivational? Do you want to listen to some motivational poem, or you want me to move ahead with the hepatobiliary imaging? साहिल, आयुष, युवराज, यशवंत, चलो आगे चलते हैं हेपेटोबिलियरी इमेजिंग में. ठीक है. सो द मोस्ट इम्पॉर्टेंट investigation that we do in hepatobiliary imaging, it is your triple phase CECT abdomen. Triple phase CECT abdomen for liver lesions. So what do you understand by triple phase? So after injecting the contrast, we are acquiring the CT in 3 phases. The first phase is the arterial phase, right? After injecting the contrast, so that first phase is acquired between 20 to 30 seconds. That will be your arterial phase. The second phase is acquired between 60 to 70 seconds. That will be your portal venous, and the third will be your delayed phase. So what is the importance of these 3 phases? You know, there are some lesions like that of hepatocellular carcinoma. So these lesions, they are going to enhance in the arterial phase and they are going to show washout in the venous phase. Lesions like your hemangioma, they are going to show peripheral nodular enhancement in the arterial phase. That is why for liver lesions we are preferring a triple phase CECT abdomen, right? A dual phase CECT abdomen can also be done. So in the arterial phase, how to differentiate between arterial and portal venous phase? Just look at the aorta. In the arterial phase, you will see that there will be enhancement of only the aorta, Okay? And in the portal venous phase, you will see that there will be enhancement of the aorta as well as IVC. Enhancement of aorta and IVC both will be present. Okay? So this is how you can differentiate between arterial phase and portal venous phase. And dual phase CT, I was talking about dual phase CT. In the arterial phase, what happens? You can see the arteries very well, like your common hepatic artery, like your gastroduodenal artery or splenic artery. All these arteries are very well visualized in the arterial phase. So if there is some tumor like your pancreatic carcinoma or your gallbladder cancer, and the surgeon has to operate that tumor, so he will like to know the relations of these arteries with the tumor. So in order to see the relations of these tumors with the arteries, we will do a dual phase CECT abdomen. Okay? So let us have a look at few important pathologies within the liver. Okay? So the first pathology is giving the central scar appearance. The central scar appearance, you can write it down. It is seen in fibronodular hyperplasia (FNH) and fibrolamellar variant of HCC. Then a hypodense lesion with a peripheral enhancement, giving the double target appearance. Is seen in liver abscess, and multiple peripherally enhancing lesions will be seen in patient with pyogenic liver abscess. So just remember that amoebic liver abscess are usually solitary, and your pyogenic liver abscess, they are multiple. Okay? And these are the ultrasound images of the liver. So these are basically your one pathology at different stages. So the first stage is your anechoic cystic lesion. This is your hydatid cyst of liver. Okay, the two classification systems that we use are your WHO classification and your Garbi classification. So in the first stage, you can see anechoic cystic lesion. In the second stage, you can see multiloculated cystic lesion in the liver. Can be seen, right? And in the third image, we can see that the membranes of the cyst have detached and they are giving this water lily appearance. That is again seen in hydatid cyst of liver. Fourth stage, there is a heterochoic lesion involving the liver. Okay, that is giving the appearance of tumor as well, pseudo tumor appearance. This is again seen in stage 4 of the hydatid cyst. And daughter cyst with a solid component within. These are multiple daughter cysts. This can also be seen in the stage 3 of the hydatid cyst. And in the stage 5, you will see a calcified lesion. Right? So clear with all the stages. So let us have a look. Ultrasound will be the investigation of choice for hydatid cyst, because you know these septations, will be seen very well on ultrasound. These septations are not very well seen on the CECT image. That is why for hereditary cyst, your ultrasound will be the imaging modality of choice. Now take some time to look at this triple phase CECT abdomen image and tell me what is your diagnosis for this case. What is your diagnosis for this case? So this, let me give you a hint, this is the most common lesion of the liver. This is the most common lesion of the liver. So it has been shown in the various phases. This is the arterial phase, portal venous phase, and delayed phase. We can see that there is some lesion in the left lobe of liver. Lesion is seen in the left lobe of liver. And if you look at the in the first phase, the lesion is showing arterial nodular enhancement, right? And in the progressive stages, okay, in the portal venous and delayed stages, you can see that the lesion is showing progressive enhancement. Arterial nodular enhancement is seen in the arterial phase, and in the rest of the stages you can see progressive enhancement. So guys, this is seen in case with hemangioma of liver, right? Another very important pathology. Okay, this is the arterial phase image and this is the portal venous phase image. Okay, so the lesion is lying in the left lobe. It is showing arterial enhancement. And in the venous phase you can see that the lesion is showing washout. So this is correct. These are the characteristic features of hepatocellular carcinoma. ठीक है. So here this is an ultrasound image of the gallbladder. ठीक है. So what is happening in this patient? There is some calculus in the gallbladder, and this calculus it is showing posterior acoustic shadowing can be seen. So this is shown by your GB calculus, gallbladder calculus. So when you see another lesion, a similar lesion like the gallbladder stone, okay, but that lesion is not showing enhancement, okay, that lesion is not showing shadowing. So this is seen in a case with GB polyp, gallbladder polyp, right? And if you look at the CT images of these patients, sometimes they can be radiolucent also, and sometimes because of the presence of nitrogen bubbles they can give the appearance of your dream car, that is your Mercedes-Benz sign can be seen. And in patients with chronic cholecystitis, you will see a wall echogenic shadow complex. Will be seen. So there will be a hyperechoic wall. Then between the hyperechoic wall and your calculi, there will be your bile in between. Anechoic bile will be present, and below that you will see multiple calculi giving the posterior acoustic shadowing. This is your features of the chronic cholecystitis. Now what is the last investigation that is being shown here? Anyone? Investigation that is being shown here, this is your HEDA scan, which is the gold standard investigation of choice for acute cholecystitis. So normally in a HEDA scan you will see that there will be uptake in the biliary system, there will be uptake in the gallbladder, and within 30 minutes the contrast will also reach into the and the tracer agent will also reach into the small bowel loops. But in patients with acute cholecystitis, you will see that there is no uptake by the gallbladder. And this will be seen in patients with acute calculus cholecystitis. ठीक है. अगर पूरा ही biliary tree नहीं दिख रहा, no uptake is shown by the biliary tree, what will be the diagnosis in that case? पूरा ही biliary tree नहीं दिख रहा, what will be the diagnosis in that case? That will be a case of biliary atresia, right? So how do you diagnose a case of acute cholecystitis? You can diagnose it through ultrasound and through CT as well, right? Investigation of choice will be CCT abdomen. So in CCT abdomen, you will see that the gallbladder walls will be thickened, and the thickening will be more than 3 mm. There will be presence of pericholecystic fluid. Pericholecystic fluid will also be seen, right? So when these features are present, you will label it as a case of acute cholecystitis. Now let us have a look at other pathologies. So this is an NCCT image of the gallbladder. We can see calcification in the wall of the gallbladder. This is your porcelain gallbladder, and porcelain gallbladder has a predisposition for malignancy. In this image, we can see in this X-ray of the abdomen, we can see that there is area of lucency in the region of gallbladder. There is area of lucency within the walls of the gallbladder as well. Within the walls of the gallbladder also there is some area of lucency, and this is a case of emphysematous cholecystitis. In the first image, this is an ultrasound image. Multiple comet tail shaped artifacts are seen arising from the anterior wall of the gallbladder, and this is seen in adenomyomatosis of gallbladder. And in the second image, we can see that the gallbladder walls are thick. Multiple echogenic foci can be seen within the lumen of the gallbladder. This is your cholesterolosis of gallbladder. ठीक है. So what is the investigation? Come on guys, what is the investigation that is being shown in this image? Anyone? Which investigation is being shown in this image? These are your MRCP images, magnetic resonance cholangiopancreatography. So these are used for seeing your biliary tract. And what are we able to see? In these images? So in the first image, we can see that this is your common bile duct, this is your left and right hepatic duct, and within this hepatic duct, common bile duct, there is a hypointense filling defect. Hypointense filling defect can be seen within this MRCP image. So this is a case of CBD stone, and remember MRCP will be the investigation of choice, choledocholithiasis. In the second MRCP image, there is a hypointense filling defect in the cystic duct. This is your cystic duct, and this cystic duct stone, it is causing compression of the adjacent CBD. It is causing compression of the adjacent CBD, because of which there is dilatation of the CBD, there is dilatation of right hepatic duct, left hepatic duct. And this is seen in patients with Mersey syndrome. Mersey syndrome. And in the third image, we can see that there is saccular dilatation of the common bile duct, and this saccular dilatation of the common bile duct, it can be diagnosed as a case of choledochal cyst. So for choledochal cyst, we use Todani classification. In the type 1, you will see that there is saccular dilatation or fusiform dilatation of the common bile duct. In the type 2, you will see that there is a diverticulum arising from the common bile duct. In the type 3, you will see that there is cystic dilatation of the distal part of the CBD, that is known as your choledococele. In type 4A, you will see that there is dilatation of both the intra and extrahepatic bile ducts, right? In type 4B, there is dilatation of only the extrahepatic bile ducts. And in type 5, that is your Caroli's disease. You will get this dot within a cyst sign. There is dilatation of only the intrahepatic biliary radicals. ठीक है. So guys, this is the normal MRCP image. ठीक है. This is your common bile duct. This is your very thin duct can be seen. This is your main pancreatic duct, which is joining the common bile duct, and this is your gallbladder. So the most common congenital anomaly of the pancreas is pancreatic dehiscence, when the dorsal pancreatic duct fails to join the ventral pancreatic duct and it is opening separately into the, this is the dorsal pancreatic duct, it is opening separately into the minor papilla. This is your pancreatic dehiscence. This is your case of pancreatic dehiscence. And in the fourth image we can see that there is dilatation of the common bile duct, there is dilatation of the pancreatic duct, and this is giving a double duct appearance. And this double duct appearance is seen in patients with periampullary carcinoma. Right. So I have shown you few images of pancreatitis also. Okay. So you read about acute interstitial edematous pancreatitis, acute necrotizing pancreatitis. So how do they look? How do they look on CT? So in acute interstitial edematous pancreatitis, you will see peripancreatic fat stranding will be seen. Okay, and the pancreas will show heterogeneous enhancement. In acute necrotizing pancreatitis, you will see non-enhancing areas. Non-enhancing areas can be seen within the pancreas. Non-enhancing areas means that part of the pancreas has become necrosed. That is why it is not showing any enhancement. And this is seen in patients with acute necrotizing pancreatitis. And after 4 weeks, if there is some peripancreatic, in this patient there was no peripancreatic fluid collection. So these peripancreatic fluid collections, they will have a wall around it and they will form pseudocyst. So this is pseudocyst of pancreas. And when this collection, walled off collection is seen within the pancreas, this will be a case of walled off necrosis. walled of necrosis. ठीक है. So we are done with the hepatobiliary imaging as well. Now I will show you few bone tumors and we will discuss some things in the arthritis, right? So Dipanshu, you will have to compare it with other people. You will have to see your ranks, right? And we don't have to say that ki marks okay hain. Our focus should be on कॉन्स्टेंटली इम्प्रूविंग आवर मार्क्स. ठीक है ना. जितना भी आ रहा है, जो भी हमारे वीक पॉइंट्स हैं उसके ऊपर देखो, जो वीक सब्जेक्ट्स हैं उनके ऊपर काम करो और धीरे धीरे इम्प्रूव करते रहो. लास्ट 10 डेज में भी यही करना है. जो आपको पता है आपके 3-4 सब्जेक्ट्स जिसमें आप अच्छा परफॉर्म नहीं करते हो, आप उन सब्जेक्ट्स को उठाओ और वो सब्जेक्ट भी पढ़ के जाओ एग्ज़ाम में. और जैसे अगर आपके किसी सब्जेक्ट्स में स्कोर्स कम आ रहे हैं, ठीक है, स्कोर्स कम आ रहे हैं, तो आप क्या करो, उन सब्जेक्ट्स को लास्ट डेज में पढ़ लो और एग्ज़ाम के टाइम में भी वो सब्जेक्ट्स हमें याद रहेंगे. एग्ज़ाम के टाइम में भी हमें वो सब्जेक्ट्स याद रहेंगे. तो लास्ट 10 डेज़ का सबसे बड़ा एडवांटेज, ठीक है, मीडियोकर स्टूडेंट के लिए यही होता है. जो इंटेलिजेंट स्टूडेंट है उसको तो सब कुछ याद है, बट जो मीडियोकर स्टूडेंट है उसके कुछ सब्जेक्ट्स वीक हैं. अगर वो सब्जेक्ट्स, वीक सब्जेक्ट्स भी हम पढ़कर एग्ज़ाम दे देते हैं तो डेफिनेटली वी आर डेफिनेटली गोइंग टू इम्प्रूव ऑन द डे ऑफ द एग्ज़ाम, राइट. सो चलते हैं बोन ट्यूमर्स के ऊपर. सो बोन ट्यूमर्स के लिए इन्वेस्टिगेशन ऑफ चॉइस विल बी एक्सरे. एक्सरे विल बी द इन्वेस्टिगेशन ऑफ चॉइस. MRI will be done to look for any neurovascular involvement, and CT scan will be done to look for any pathological fracture, to look for any periosteal reaction. And radionuclide studies like your technetium MDP scan, right? It can show metastasis also, right? And there are two lesions which will not show uptake on technetium MDP scan. This you should know. One is your multiple myeloma, and second is your thyroid metastasis, which are not going to show uptake. And PET scan can be done for diagnosis, for staging, to look for any response to the treatment. So we have this ALTA protocol for the bone tumors. So we will look at the age of the patient, we will look at the location of the tumor, we will look at the imaging appearance, and we will look at the transition zone. ठीक है. सो पूरा डिटेल में कवर करना तो बड़ा डिफ़िकल्ट है, बट इम्पॉर्टेंट पॉइंट्स देखते हैं हर ट्यूमर के. ठीक है. सो द ट्यूमर्स विच आर कॉमन बिटवीन 0 to 20 years of age. सो दीज आर योर simple bone cyst, aneurysmal bone cyst, ठीक है. Then your osteoid osteoma, these are common in less than 20 years. Chondroblastoma, which we will discuss that it is present in the epiphyses of the long bones, and it is common in less than 20 years of age, before skeletal maturity. Malignant tumors less than 20 years of age, very important. Osteosarcoma, and you have Ewing sarcoma. Between 20 to 40 years of age, you have enchondroma, fibrous dysplasia, then parosteal osteosarcoma, and giant cell tumor. Very important, tumors in more than 40 years of age. So remember 3 tumors which are common in more than 40 years. So this is your multiple myeloma, chondrosarcoma, and metastasis. ठीक है. So the tumors common in the epiphyseal location, this can be remembered with a mnemonic ECG. So E stands for epiphysis, C for chondroblastoma, G for giant cell tumor. And we have already discussed that giant cell will be present after skeletal maturity, more than 20 years of age, and chondroblastoma will be present in less than 20 years of age. So you will look at the growth plate. If growth plates are fused and the lesion is located in the epiphysis, it will be your GCT. And if the growth plates are not fused, lesion is located in the epiphysis, it will be your chondroblastoma. So here in this image we can see that the lesion is located in the epiphyseal location, and the growth plates, these are not fused. The growth plates are not fused. It means that the age of the patient is less than 20 years of age, and this is a case of chondroblastoma. Chondroblastoma. Lesions located in the diaphysis can be remembered with the mnemonic coffee. Coffee with a double E, where C stands for your cyst, simple bone cyst, aneurysmal bone cyst. O for osteoid osteoma. F for fibrous dysplasia. E for Ewing sarcoma. E for enchondroma, right? And rest of the bone tumors you can see in the diaphyseal location. So here is one more lesion that is located in the diaphysis of the long bone. There is moth-eaten pattern of bone destruction, which you will not be knowing, okay, which you cannot understand right now. But what you can understand is that there is a onion peel type of periosteal reaction. So every one of us know that onion peel type of periosteal reaction, it is seen in your Ewing sarcoma. So हमने अभी लॉन्गिट्यूडनली लीजन्स को डिवाइड कर लिया एपिफाइसिस में, डायफाइसिस में और मेटाफाइसिस में. सो लीजन्स को हम ट्रांसवर्स लोकेशन के बेसिस पर भी डिवाइड कर सकते हैं. ऑन द बेसिस द लीजन्स कैन बी लोकेटेड इन द सेंट्रल पार्ट, इन द इसेंट्रिक पार्ट, इन द कॉर्टेक्स, इन द जक्स्टाकॉर्टिकल लोकेशन. सो लेट अस सी फ्यू एग्जांपल्स. ठीक है. सो दिस इज अ लीजन विच इज लोकेटेड सेंट्रली and there is one bony fragment can be seen. This is the hinge fragment sign seen in patient with simple bone cyst. In this image you can see that the lesion is located eccentrically. It is located in the epiphysis. So two possibilities, giant cell tumor and chondroblastoma. And also we can see that the epiphyses are fused, growth plates are fused. It means that the lesion is present in more than 20 years of age, and this is a case of giant cell tumor. In the third case, we can see that the lesion is located in the cortex of the bone, cortical location, and there is a solid type of periosteal reaction. This is and the patient has history of night pains that is relieved by NSAIDs. This is a case of osteoid osteoma, that is lesion located in the cortex. And the third is your parosteal osteosarcoma, more common in the femur, lower femur, right, distal femur, where you can see a lesion located in the arising from the cortex of the bone. Another very important juxtacortical lesion that you should be aware of is your osteochondroma, which will arise from the cortex of the bone. Okay. So you can also identify tumors based on their specific locations, right? If a lesion is located in the clivus, you can say that it can be a case of chordoma. Okay. Chordoma is present in the clivus and the sacrum part of the bone, and you can see ficelliferous cells. If the lesion is located in the fingers of the hand, it can be an enchondroma. If there are multiple enchondromas, it is associated with Olier's disease, and multiple enchondromas with soft tissue hemangiomas will be seen in your Maffucci syndrome, right? And in this patient the lesion is located in the tibia. So the lesion which is located in the common in the tibial location, it is your adamantinoma, right? So I have told you about the age, I have told you about the location. Then you should know about the zone of transition. So zone of transition, it can be a wide zone, it can be a narrow zone. Wide zone means that the interface between the normal and the abnormal bone, it is wide. ठीक है, जैसे ये एक लीजन है, इसमें आप बता सकते हो कि ये नॉर्मल बोन है और ये वाली एबनॉर्मल बोन है, बता सकते हो, ठीक है। तो इसका मतलब जो इंटरफेस है नॉर्मल और एबनॉर्मल बोन का वो बड़ा नैरो है, दैट इज सीन इन बिनाइन लीजन्स। बट अगर कोई मैलिग्नेंट लीजन है उसमें क्या होता है कि नॉर्मल और एबनॉर्मल बोन बताना बड़ा मुश्किल है, क्योंकि वो लीजन इतनी तेज़ी से ग्रो कर रहा है, नॉर्मल बोन को टाइम ही नहीं मिल रहा कि उसके अराउंड कोई रिएक्शन करे, बोन रिएक्शन करे, ठीक है। सो दैट इज सीन इन मैलिग्नेंट लीजन्स। सो दिस इज बेसिकली योर वाइड जोन ऑफ ट्रांजिशन. So we have discussed A, L and transition zone. Fourth we will discuss about the appearance. So appearance में हम क्या देख सकते हैं? What we can see in the appearance? We can see about the periosteal reaction. ठीक है? If the lesion is showing solid periosteal reaction is seen in osteoid osteoma. ठीक है? अगर एक ही single lamella is seen, single lamellated type of periosteal reaction is seen. This is your bone and a single lamella is seen. This is seen in osteomyelitis. Multiple lamellae are seen, giving the onion skin appearance. That is your Ewing's sarcoma, located in the diaphysis of the bone, less than 20 years of age. ठीक है? And wide zone of transition. All these are important points for Ewing's sarcoma. And if there is some sundray pattern of periosteal reaction, it will be seen in osteosarcoma. And Codman's triangle will be seen in patients with, again, osteosarcoma, right? So here this is a patient that is having a ground glass matrix within the bone. It is taking the Shepard-Crook deformity. This is seen in fibrous dysplasia. So fibrous dysplasia is associated with two syndromes. One is McCune-Albright syndrome. In McCune-Albright syndrome, you will see Café-Ollis spot, skin lesions will be seen. And in Mazabarot syndrome, you will see multiple myxomas, intramuscular myxoma will be seen. ठीक है? So और कुछ important signs within the bone tumors. This is the polka dot sign, seen in hemangioma of the vertebra. Polka dot sign and your corduroy cloth appearance. ठीक है? And in the first image we can see a bone tumor that is arising from the cortex of the bone. This is a case of osteochondroma. So for osteochondroma, you should know that it has a chances to get malignant also, right? Malignant भी बन सकता है. और कौन से ट्यूमर में malignant बन सकता है? Chondrosarcoma में. So there are some signs in which can tell that the tumor is turning malignant. So these signs include bone pain, increase in the size of the lesion after skeletal maturity, then the thickness of the cartilaginous gap. If it is more than 3 centimeter, then it has a chance to turn into a malignancy, right? Multiple osteochondromas, these are associated with a syndrome that is known as diaphyseal eclasis. So simple bone cyst में two signs, one is your fallen fragment sign and is your hinge fragment sign. In hinge fragment sign, the fractured bone segment, it will be attached to the walls of the cyst. ठीक है ना? बट फॉलन फ्रेगमेंट साइन में क्या होगा कि ये जो लीजन है, ये जो बोनी फ्रेगमेंट है, इट विल कम इनटू द सिस्टिक कैविटी, राइट? सो यू शुड नो फ्यू बोन ट्यूमर्स which are having fluid levels. So which are these bone tumors which are having these fluid levels? So these can be remembered with a mnemonic, that is GOAT. goat, where G stands for giant cell tumor, O for osteoblastoma, A for aneurysmal bone cyst, and T for telangiectatic osteosarcoma. So this is an MRI image in which you can see multiple blood fluid levels. So this is your fluid part and this is your hemorrhage part within the cystic lesion, right? So again, this is again a bone specific site for one bone tumor that is present in the calcaneum of the bone. This is your intraosseous lipoma of the calcaneum, and the name of the sign is Cockade sign. So there is one radiolucent lesion, and within that radiolucent lesion there is calcification within it. Name of the sign is Cockade sign. ठीक है. Metastasis, most common primary tumor causing bone metastasis in males, it is lung cancer. In females it is breast cancer. Most common primary tumor causing lytic mets, it is again your lung cancer. And most common primary tumor causing blastic metastasis, it will be your prostatic carcinoma. Right. So this is an X-ray of the pelvis and X-ray of the LS spine. What we can see, multiple sclerotic areas can be seen in the hip, in the right sacroiliac joint, and within the spine also we can see multiple sclerotic areas. So these are nothing, these are but your osteoblastic mets from the prostatic carcinoma. ठीक है. So अब कुछ appearances देख लेते हैं lytic metastasis की in the vertebra. So normally if you will look at the vertebra, you will be able to see the two pedicles. If one pedicle is absent, because of the destruction by the lytic mets, it is called as winking owl eye sign. In the second image we can see that there is destruction of both the pedicles. This is your blind vertebra. In the third image we can see that there is eccentric cortical destruction by a mets, that is mets of the lung carcinoma. This is the cookie bite appearance of the lung carcinoma. And in the third image we can see that the mets have become expansile. Okay, they have caused a break in the cortex. These are your blowout mets, and these are seen in patients with renal cell carcinoma and thyroid metastasis. ठीक है. तो अब हम कुछ ट्यूमर्स देख लेते हैं that are common in more than 40 years of age. So here we are getting this raindrop skull. ठीक है. Multiple lytic lesions can be seen in the skull of variable size. ठीक है. And here there is flattening of the vertebra. The lesion is involving the vertebra and it has caused the vertebra to collapse. Very good. This is seen in multiple myeloma. A lesion common in the pelvis that is having an ring and arc shaped type of calcification. Ring and arc shaped type of calcification can be seen, and this ring and arc shaped type of calcification, this is seen in chondrosarcoma. Chondrosarcoma. ठीक है. Isolated lytic lesion of the skull that gives a hole within a hole appearance. Hole within a hole appearance is seen in eosinophilic granuloma. Eosinophilic granuloma. And you can also have a vertebra plana in these patients. That was your thinned out vertebra giving a silver coin appearance. ठीक है. So bone tumors भी हमने कर लिए. We have covered neuroradiology, important science, chest radiology, GIT radiology, hepatobiliary, bone tumors. ठीक है. अब हम last we will discuss few important signs from the section of arthritis. ठीक है ना. arthritis को कैसे identify करेंगे, and this will be the last topic for today, right? And tomorrow we have another sprint session of pathology by Dr. Ranjit sir, right? Do attend that also. ठीक है. So सबसे पहले we should know how to differentiate between an inflammatory arthritis and osteoarthritis. ठीक है. Just imagine yourself sitting in the OPD, orthopedics OPD. You get a knee X-ray done for the patient who has joint pains, and you have to decide कि उसको osteoarthritis है या inflammatory arthritis है. How will you do that? So we will just check it in the schedule, right? So just check your schedule again. So we will see the joint space narrowing. Very good. So in both the cases you will see joint space narrowing, but what is going to happen in patient with inflammatory arthritis? Okay, you will see that there is यूनिफॉर्म लॉस ऑफ जॉइंट स्पेस. इसमें क्या हो रहा है कि बोथ द लैटरल एंड द मिडिल कंपार्टमेंट देयर इज लॉस ऑफ जॉइंट स्पेस, बट इन ऑस्टियोआर्थराइटिस यू विल सी दैट द जॉइंट स्पेस नर्विंग इज प्रेजेंट मोर ऑन द मिडिल पार्ट, मोर इन द मिडिल कंपार्टमेंट एज कंपेयर टू द लैटरल कंपार्टमेंट. देयर इज नॉन यूनिफॉर्म लॉस ऑफ जॉइंट स्पेस. Then second very important point, you are going to see erosions in patients with inflammatory arthritis. Erosions will be seen. Marginal erosions will be seen, but erosions will be absent in the osteoarthritis. Can you appreciate here? There is a marginal erosion seen in this patient, and osteophytes will be present. In osteoarthritis. They will be absent in inflammatory arthritis. ठीक है. So rheumatoid arthritis में कुछ important features. Rheumatoid arthritis, it is a type of inflammatory arthritis, right? So we are going to see erosions. Marginal erosions will be seen in this patient. There will be juxta-articular osteopenia in this patient, right? If you look at the fingers of the hand, there are few deformities. One is botulate deformity, and the other is your swan neck deformity. So in swan neck deformity there will be flexion of the DIP and extension of the DIP. Swan neck deformity. But when there is flexion of PIP and extension of DIP, it will give a deformity that is your botulate deformity. ठीक है. And other deformities that you can see that there will be erosion of the carpal bones, that will give a sign that is known as spotty carpal sign. ठीक है. And you know there is one deformity in which there is extension at the proximal interphalangeal joint and your first metacarpophalangeal joint, that is your hitchhiker's thumb. Mallet finger, in which there is flexion of the distal interphalangeal joint, that can also be seen in patients with rheumatoid arthritis. ठीक है. Now patient coming with history of back pain. ठीक है. So one arthritis that is going to involve, it will be your ankylosing spondylitis. So what are the imaging features that you will see in ankylosing spondylitis? So you will see in ankylosing spondylitis, if you get an MRI done, that will be the investigation of choice. You will see edema on stir images, stir in which fat is suppressed. Stir is one sequence in which fat is suppressed. So edema will be seen in the bilateral sacroiliac joints, that will appear as increased signal around the SI joint. If you look at the X-ray, you will see that in the first stage there will be irregularity in the joint space. Okay. Then there will be joint space narrowing, and in the third stage you will see that there will be fusion of the SI joint. There will be ankylosis of the SI joint. So this is how your sacroiliitis will evolve in patients with ankylosing spondylitis. And this ankylosing spondylitis, it is also going to involve your anthesis. What is anthesis? Anthesis is the region of junction of tendon or ligament with the bone. Anthesis is the region of junction of tendon or ligament with the bone. So at those points you are going to see inflammatory changes. So in the vertebrae, what will happen when there is a ligament connecting the two vertebrae? Okay, at the junction where this ligament is joining the vertebrae, you will see that there will be erosion of the bone. And this sign is known as Romanus lesion. Erosion of the ends of the bone gives an appearance that is known as Romanus lesion. Now what will happen? Now this Romanus lesion, it will get healed by sclerosis. होगी उसमें, healing होगी. And when there is healing in that lesion, it will appear radiodense, and it will give a sign that is known as your shiny corner sign. So normally the vertebrae are like this, the anterior vertebrae are like this, but when there is erosion of the bone, the vertebrae will become barrel shaped. So you will see barrel shaped vertebra in these patients, right? There will also be osteophytes present between the two vertebrae that are connecting each other. So these are known as syndesmophytes. These are known as bridging syndesmophytes, and bridging syndesmophytes will give a bamboo spine appearance. Okay? And also there can be calcification also within the ligaments. When there is calcification of the interspinous ligament, there is calcification, it will give a sign that is known as Dagger sign. Okay? When there is calcification of the paraspinous ligament, it will give us a sign that is known as railroad track sign. And when there is calcification of both the paraspinous ligament and interspinous ligament, it will give a sign that is known as trolley track sign. Okay? So one more very important appearances. So this is the case of psoriatic arthritis, in which you will see erosions as well as periosteal reaction. And this will give an appearance that is known as mouse ear appearance. Mouse ear appearance will be seen, right? And sometimes there will be central erosion will be seen. So central erosion will be seen in the erosive arthritis, and that gives an appearance that is known as gullwing sign. Okay. Now here again a patient comes with swollen first metatarsophalangeal joint, swollen red first metatarsophalangeal joint. You do an X-ray for this patient. Okay, X-ray for this patient. What do you find on this X-ray? On this X-ray you find that there is erosion of the juxta-articular as well as marginal erosion of the first first metatarsophalangeal joint. ठीक है. So what do you suspect? So this is seen in a patient with gouty arthritis. Gouty arthritis. So in gouty arthritis there is hyperuricemia, very good medico forever. There is hyperuricemia and there is deposition of monosodium urate crystals in these patients. Monosodium urate crystals are deposited and they cause an inflammatory reaction. Because of the inflammatory reaction to the deposition of monosodium urate crystals, there is erosion in the first metatarsophalangeal joint. And this is a newer imaging modality, that is your dual energy CT, that can separately visualize your monosodium urate crystals that are known as tophi. Okay, they can separately, if you do a normal CT scan, they will just appear like calcific deposits, but if you do a dual energy CT scan, you can quantify this monosodium urate crystals. You can see the monosodium urate crystals separately, right? So dual energy CT scan is done in gouty arthritis, and in this image we can see that there is calcification of the articular cartilage. There is calcification. This is known as chondrocalcinosis, and this is seen in pseudo gout, that is your CPPD, calcium pyrophosphate dihydrate crystal deposition disease. ठीक है. So in the next case, what you are able to see, बड़े अजीब से joints दिख रहे हैं, disorganized हैं, they are eaten up, even all the bones cannot be seen. Here the head of the femur is not seen, here the phalanges are not seen, here the carpal bones are not seen, here you can see that there is debris and there is dislocation of the elbow joint. So guys, all these are important features of neuropathic joints or Charcot joint, ठीक है, seen in patients with diabetes mellitus, ठीक है, where there is absence of sensation of the foot, proprioception absent है in Taves dorsalis patients, right? So in those patients you can see this Charcot joints. And what are the 6 Ds? You will see that the joints will be disorganized, the joints will be destruction of joints will be there, joints will be distended with fluid, joints will be there will be increase in the density of the joints, and there will be debris within the joints, and last there will be dislocation of the joint. So just remember the 6 Ds are seen in Charcot's joint. ठीक है. सो ये हमने केस डिस्कस कर लिया. ये था ऑस्टियोआर्थराइटिस में कुछ फीचर्स होते हैं. वन इज़ नॉन यूनिफॉर्म रिडक्शन इन द जॉइंट स्पेस. सबकॉन्डल स्क्लेरोसिस मिलेगा. यू विल सी द ऑस्टियोफाइट्स विल बी सीन. देन subchondral sclerosis, then you will see subchondral cysts will also be seen, that are known as GOT. In this third x-ray we can see that there are multiple calcific loose bodies can be seen around the knee joint. So this is seen in synovial osteochondrometaplasia. So basically there is metaplasia in the synovial tissue and it starts producing cartilage, and these cartilage will calcify and this will appear as loose bodies around the joint. In the fourth x-ray we can see that there is flowing calcification, bumpy contour of the anterior cervical vertebra. This is due to the calcification of the anterior longitudinal ligament seen in diffuse idiopathic skeletal hyperostosis. ठीक है. सो अब हम कुछ मेटाबॉलिक बोन डिसऑर्डर्स डिस्कस कर लेते हैं, इंपॉर्टेंट साइंस. तो सबसे पहले तो स्कर्वी, विटामिन सी डेफिशिएंसी इज देयर. व्हाट आर यू एबल टू सी? सब पेरियोस्टल हेमरेजेस. ठीक है. देन यू विल सी ट्रमर फील्ड जोन ऑफ रेरिफैक्शन. ठीक है. डेंस जोन ऑफ प्रोविजनल कैल्सिफिकेशन. रिंग एपिफाइसिस विल बी सीन. ring epiphysis will be seen. Okay. In rickets, vitamin D deficiency in children, you will see cupping, fraying, cupping and fraying of the metaphysis. Cupping, fraying and fraying of the metaphysis will be seen. Okay. Cupping, fraying and widening of the metaphysis will be seen. And you will also see that the costochondral junction, they will be widened. Costochondral junction, they will be widened, and this will give an appearance that is known as rachitic rosary. Rachitic rosary. And in the fifth case, we can see that there is a radial resorption of the phalanges, subperiosteal radial resorption of the phalanges, and this is seen in hyperparathyroidism. Hyperparathyroidism. Okay. Now talking about few important skeletal dysplasias. Right. So important skeletal dysplasias. In the first image, we can see that there is shortening of the proximal limb. So this is your rhizomelia. In the second image, we can see that there are bullet nose shaped vertebra. The third image, we can see that there is gap between the third and the fourth finger. This is your gap between the third and the fourth finger. This is your trident hand appearance. And in the fifth image, we can see a champagne glass type of pelvis. So Dr. Hope, you will tell me what is the diagnosis in this case. You have to interact with me. You have to tell me the diagnosis. So there is rhizomelia, bullet nose shaped vertebra, trident hand appearance, and champagne glass pelvis. Champagne glass pelvis is seen. So what is your diagnosis for this case? Come on guys, simple question. So this is seen in patients with achondroplasia. Right. Now here, this is a very interesting image, one of my favorite images. So here in this image, you can see that there are two people. What do you see in this image? Are two people hugging each other? Can you see that there are two people hugging each other? No, these are not two people hugging each other. Right? These are not two people hugging each other. So this is just one patient who is able to touch both his shoulders. Try touching both of your shoulders. Will you be able to do that? Touching both your shoulders? No. But this patient is able to do that. This patient is able to touch both his shoulders. You get an X-ray done for this patient. You see that the clavicle of lateral part of the clavicle is absent. And this is seen in a case with cleidocranial dysplasia. ठीक है. So कुछ और important skeletal dysplasias. So there is calcification in the epiphysis of the bones. This is seen in the chondrodysplasia punctata. ठीक है, also known as Conradi-Hunterman syndrome. It is associated with warfarin use in females during early pregnancy. Abnormalities was that clavicle was absent in that patient. Seen in cleidocranial dysplasia. ठीक है, associated with warfarin use. In this you can see prominent posterior iliac horns. This is associated with absent nails, absent patella. This is your nail patella syndrome. And this is your absent radius. In this patient, radius is absent. And this is your radial ray syndrome, and multiple congenital heart diseases can be associated with it. So this is a patient who has very tall, long fingers, patient came to you with pain in the pain in the abdomen, you get a CT done and there was aortic dissection in this patient. So can you diagnose? This was a case of Marfan syndrome. So few points about mucopolysaccharidosis. J-shaped sella, inferior beaking of the vertebra. These are characteristic features of Hurler syndrome. Okay, they can also have cloudy cornea, right? If the beaking is present in the central part of the vertebra, it is seen in Moriquo syndrome. Inferior beaking is seen in your Hurler syndrome. Central beaking is seen in Moriquo syndrome. Okay. Then in Moriquo syndrome, your dens of the axis can be absent. Yes, triple bubble is in jejunal atresia. Dens of the axis can be absent. And this is seen in again Moriquo syndrome. Your head of the femur can be dysplastic, and this can result in dislocation of the head of the femur. All these are seen in Moriquo syndrome. H-shaped vertebra. Just remember, it is seen in sickle cell disease. H-shaped vertebra. Fish mouth appearance of the vertebra. Is seen in osteoporosis. Picture frame vertebra. Paget's disease. Rugged jersey spine. Secondary hyperparathyroidism. ठीक है. Barrel shaped vertebra. We have discussed ankylosing spondylitis. Then vertebra plana. Silver coin appearance of the vertebra is seen in multiple myeloma and eosinophilic granuloma. So these are the important appearances of the vertebra that you guys should know, right? So just last two slides, Medico forever. Last two slides, okay? So this is a patient who had blue sclera. There was osteoporosis in the bone. There were some abnormal discoloration of the teeth, that is known as dentinogenesis imperfecta. There was hearing defect also, that is otosclerosis was there in this patient. So all these are important features which are seen in patients with osteogenesis imperfecta. Just remember these four major criteria: blue sclera, osteoporosis, dentinogenesis imperfecta, and otosclerosis. Just remember that multiple fractures are not in the major criteria of osteogenesis imperfecta. Okay. So last slide for today. So here in this patient you can see that there is diffuse increase in the density of the bones. Is there. Within the fingers, within the vertebra, you will see bone within a bone appearance. So these patients, they have problem in the osteoclastic activity, because of which there is increased deposition of calcified cartilage, and there is increase in the density of the bones. And these patients come with anemia, thrombocytopenia, and infections. And you will see that they will have increase in the density of the bones, also known as marble disease, because bones look like marble. Right? So guys, this was all for today. So all the best for your upcoming NEET PG exam, and just keep working. Just focus on improving every day, right? Forget about what other students are getting, what marks other students are getting, what ranks they are getting. Just focus on yourself, focus on your weak points, focus on your weak subjects, and the only aim should be that you have to keep on improving, right? So guys, this was all for today. All the best and keep working hard.